Welcome back, everyone. Hope you have your tea. Let us resume our conference with the same energy which we had in the first session. Now we'll start our second session, Hepatology. Now we'll start our second session, Hepatology. The first topic is prevention of decomposition in a patient with compensated liver disease.
Welcome all to Hepatology session. So we'll begin with this. For this we have very eminent faculties throughout our nation. And the first topic is prevention of decompensation in a compensated liver disease by Dr. Akash Shukla. Unfortunately, he had some medical emergency. Dr. Sareen also had medical emergency, but they all will be joining us. So I would like to request Dr. Akash Shukla to begin his talk. Before that, Haley will be announcing all chairpersons. Please come on stage.
I would like to invite Dr. Saumin Shah sir, Dr. Umesh Parmar sir, Dr. Pat Shah sir and Dr. Sameer Padgar sir as a honorable chairperson. The speaker will be invited by the chairperson.
So good afternoon everyone. To start with the hepatology session, we have the first lecture from our eminent speaker, Professor Akash Shukla. So the first topic is prevention of decompensation in the case of cirrhosis. Over to you, Dr. Akash.
Dr. Akash, I request you to unmute yourself.
Yeah. Good evening, everybody. Am I audible and are the slides visible?
Yes, sir, you are audible, sir.
Okay, great. So at the outset, I must thank Dr. Yogesh and his team and the organizing team for having me here. Unfortunately, I could not make it in person because of something urgent, but I'm sure we'll try to make it up in the next few minutes. I will be talking on prevention of first decompensation in a patient with cirrhosis. I bring greetings to you from Department of Hepatology at the Sir H.N. Reliance Foundation Hospital, Girgaon, Mumbai. We have a team of very brilliant hepatologists and transplant surgeons and intensivists. So what I'll start off with is in a patient who has got cirrhosis, what are the non-invasive tools that we use to diagnose and monitor patients who have got compensated cirrhosis, what is now called as CACLD or compensated advanced chronic liver disease and portal hypertension. So we use both the terms CACLD and compensated cirrhosis, but they don't mean the same thing. Today we have stopped using the word compensated cirrhosis because we know that cirrhosis is not something which is uniform, and there will be parts of the liver which are cirrhotic, and there are some other parts of the liver which are still F2, F3 fibrosis. However, if these patients behave like cirrhosis, then we would call them, because they behave like cirrhosis, we call them compensated advanced chronic liver disease. Also today we know that these patients we may call cirrhosis, and by definition cirrhosis is irreversible. But many patients who have what we call as cirrhosis actually reverse back to F3, F2 or even sometimes F1 fibrosis. And therefore, we have stopped using the word compensated cirrhosis and now we use the term CACLD or compensated advanced chronic liver disease. Now, how do we stratify? The first stratification of which patients you want to follow up closely and target for preventing decompensation versus those patients where you can leave them alone, not worry about decompensation in the near future. So what we do is we do a fibroscan for them. If the fibroscan is less than 10 kilopascals, then this patient has less than 1% risk of decompensation in the next 3 years, and therefore we need not be worried about decompensation in these patients. The transition from being compensated to decompensated carries a very high mortality risk, and that is why we have to prevent this crucial step from compensation to decompensation. For this, we need to understand that we need to divide our patients with CACLD into 2 stages. Whether they have a clinically significant portal hypertension or they do not have a clinically significant portal hypertension. If they do not have a significant portal hypertension, then these patients are not going to decompensate soon. But if they have a clinically significant portal hypertension, their risk of decompensation is very high. And therefore, it is in this group we want to prevent decompensation. So what is decompensation? What are the events that will define decompensation? One is presence of overt ascites or pleural effusion in the presence of a high SAG ratio, or presence of overt hepatic encephalopathy. So not grade 1, not MHE. It has to be overt hepatic encephalopathy, at least grade 2. And third decompensating event is a variceal bleeding. Now, what mechanisms make a patient go from a compensated to a decompensated stage? One is natural progression of the disease. So if untreated hepatitis B, untreated hepatitis C, or patient consumes alcohol continuously, then he can progress. Or there is a superimposed another cause of liver injury. That is what we call as ACLF. And then the third is development of hepatocellular carcinoma, portal vein thrombosis, and other complications of cirrhosis. So this concept of CACLD was introduced in Boveno 6. Now, how on the basis of this fibroscan value, you can stratify your patients into no CACLD, assumed CACLD, without portal hypertension, or we can, even on fibroscan, diagnose patients with portal hypertension. So if you find that the fibro value is more than 25 kilopascals, you can safely tell this patient that he has got clinically significant portal hypertension. Between the stiffness of 20 to 25, again, this patient has got a high chances of portal hypertension if the platelet count is less than 1,50,000. Between 10 to 15 kilopascals, this patient would require an endoscopy to see whether they have a portal hypertension or not, or you do Doppler for looking at collaterals in the abdominal circulation. Once you diagnose somebody with a compensated advanced chronic liver disease, this fibro value should be repeated every 12 months to see if the patient is improving or worsening and whether your interventions are having a desired implication. A clinically significant decrease in LSM, that is, whom do you say is improving? You say that the person has improved and his risk of dying has reduced or risk of decompensation has reduced is if the liver stiffness decreases by at least 20% and the absolute value falls to below 20 or an absolute value falls below 10. Then this patient is extremely low risk of having a decompensation in the next 3 years. Whereas when do you say progression? You talk of rule of 5. So at 10 kilopascals and above, with an increment of every 5 kilopascals, there is an increased risk of decompensation and liver-related death, and therefore you will always be concerned when there is an increment by at least 5. In patients with CACLD, sorry. So this brings us into the focus of the machine, that is FibroScan. Now what you must have in your FibroScan machine is the 630 Expert machine with a smart view, which can measure not only the liver stiffness but also the splenic stiffness. Why do you need the splenic stiffness? Because if you use splenic stiffness, then you can confidently tell the patient whether he has got portal hypertension or not, whether he needs an endoscopy or not. So if you have a FibroScan machine and the splenic stiffness is less than 21 kilopascals, this patient does not need an endoscopy. You can safely tell this patient you do not have portal hypertension. Whereas if you have a splenic stiffness of more than 50, then this patient definitely needs endoscopy. He will have clinically significant varices which may require intervention. Similarly, endoscopy can be avoided if the splenic stiffness is less than 40 kilopascals and even if the liver stiffness is more than 20 and the platelet count is less than 1,50,000. Now let us see, how do we manage these patients? Can we remove or suppress the etiology? This is the single most important intervention that we can do to prevent the first decompensation. So in a patient with hepatitis C, it is achieving sustained virological response. In chronic hepatitis B, it is keeping the HBV DNA undetectable. And in alcoholic liver disease, it is long-term abstinence from alcohol. In addition, we have to treat the components of metabolic syndrome. So if you have a hepatitis B patient, you have to still manage this patient's weight, you have to manage this patient's obesity, diabetes, and alcohol consumption. Even if the person is NASH-related cirrhosis, and he says, can I drink once in a while, once in 3 months? The answer is no. So it is zero alcohol, even if the etiology of the liver disease is hepatitis C or hepatitis B or any other cause. So all these metabolic factors have to be addressed in addition to management of the etiology. Now let us see what we can do in addition to treating the etiology. So the first thing is, can we use statins in patients who have got NASH? The answer is yes. We must use statins in patients who have an indication for statins. If they have dyslipidemia, even if they have cirrhosis, we must still use statins. Even if they have high SGOT, SGPT, we must still use statins. Similarly, aspirin can be used in patients with cirrhosis, even in the presence of varices, because if there is an indication for giving aspirin, it reduces additionally the risk of hepatocellular carcinoma, liver-related complications, as well as it is shown to improve overall survival. But you do not give routinely aspirin to patients with cirrhosis. It is only when there is an indication for aspirin, for example, somebody has had an angioplasty, somebody has a ischemic heart disease or a peripheral vascular disease, then you would not resist from giving aspirin to this patient. Similarly, would you use rifaximin? Yes, we would use rifaximin in somebody who has had hepatic encephalopathy. So, for secondary prophylaxis, it is indicated, as well as in patients who have had encephalopathy in the past, and if this person is going a TIPS procedure, then you would use rifaximin. So, another worry which people have in doing TIPS is that the patient will develop encephalopathy. The answer is very small number of patients will develop encephalopathy if you have done TIPS the right way. The key is doing TIPS the right way, having the right diameter, having the right pressures, and that is where experience and expertise in doing TIPS comes into the picture. And that is why in good centers, high volume centers which are doing 1 to 2 TIPS every week, you find that the risk of hepatic encephalopathy is less than 2%. But if you see centers which are doing 1 TIPS a year or 2 TIPS a year, there you will find the risk of encephalopathy being more than 30 to 40%. Rifaximin should not be used beyond these indications. It should not be used for primary or secondary prophylaxis for SBP. Then comes, can we use blood thinners? So the answer is, we can use these blood thinners, anticoagulants safely in patients with child A cirrhosis and with caution in child B cirrhosis. Now let's come, can we do something else to prevent the first decompensation? So for this, the first thing we need to understand is that minimal amount of ascites only detected in imaging procedures cannot be considered as decompensation. Similarly, jaundice alone cannot be considered as the true first decompensation. So if somebody has just bilirubin going from 1 to 4, no ascites, no encephalopathy, no GI bleed, this patient is not decompensated. So the first step in treating a patient who has got compensated advanced chronic liver disease is to treat the non-hepatic comorbidities. They are the first step in preventing decompensation. Second is correction of sarcopenia and frailty. Very important. We have to ensure that our patients develop the muscle mass. Do not restrict their protein intake. Do not restrict their intake of calories. So even if they have NASH, do not make them very frail, very lean and thin with loss of muscle mass. It is good to lose visceral fat, but it is not good to lose muscle mass. So in a patient who has got jaundice or somebody who has got liver cirrhosis, we should not restrict consumption of a balanced diet. They must have essential fatty acids, they must have sufficient carbohydrates, and they must have sufficient amount of proteins. Then we have to ensure that these patients remain infection free. Bacterial infections are very common in patients with cirrhosis, especially those with portal hypertension, and that very often leads to decompensation. You will have a patient who has cirrhosis for long period of time, then develops a pneumonia or a urinary tract infection or a cellulitis, and then develops hepatic decompensation. So we have to be very cautious about these events. In addition, can we prevent the superimposed liver damage? So the first is a superimposed liver damage with alcohol can cause worsening. So these patients should be completely away from alcohol. The another insult which can cause decompensation is acute viral hepatitis, whether hepatitis A, E or B, and therefore to prevent this, we must vaccinate our patients for hepatitis B and hepatitis A, and for hepatitis A and E, healthy hygiene practices should be followed. Drug-induced liver injury is another common phenomenon, and therefore we must avoid all NSAIDs in our patients. We must avoid unindicated herbal medications or alternative therapy where the safety in liver diseases is not established. HCC is another factor which can cause decompensation, and therefore all these patients must be under major surveillance with every 6 monthly ultrasound, alpha fetoprotein and PIVCA2 to ensure that you pick up hepatocellular carcinoma at an early or a very early stage where before decompensation you can offer curative therapy. Now treatment with non-selective beta blockers like carvedilol, propranolol or nadolol prevents decompensation in patients who have got significant portal hypertension. If you have to choose between the propranolol, nadolol or carvedilol, then carvedilol, because of its intrinsic anti-alpha adrenergic vasodilatory effects, it has got a greater potential to reduce the portal pressure. Not only that, it has got also greater benefit in preventing decompensation by reducing the gut permeability and bacterial translocation. It has got a much better tolerance than traditional non-selective beta blockers, and studies have shown that improves survival. Therefore, whenever possible, we put our patients now on carvedilol and not on propranolol. Those patients with compensated cirrhosis who are on adequate doses of non-selective beta blockers do not require a screening endoscopy, because even if you find varices, your endoscopy is not going to change your management. So, to summarize, my dear friends, we have patients who have got compensated advanced chronic liver disease. That is the term that we use. In these patients, we have to not only focus on monitoring their progression of fibrosis using a fibroscan machine every year, but we have to also ensure that we treat the root cause, that is the etiology of liver disease. We treat all the comorbidities that are there in these patients, and in addition, we use beta blockers rifaximin, aspirin, statins, wherever indicated to reduce the further risk of decompensation. I'll thank you very much, and I'll be happy to take any questions if there are.
Thank you, sir, for the crisp talk. Forum is open for question. Sir, lactulose has some role in prophylaxis or not?
So, lactulose should be used in patients with hepatic encephalopathy as a treatment. As a prophylaxis, it should be used in patients who have constipation in the presence of cirrhosis, because we know that constipation can precipitate hepatic encephalopathy. So that is the only other drug which you can use to prevent hepatic encephalopathy. But in general, I think you will not find hepatic encephalopathy in a patient who is otherwise very well compensated only because of mild constipation. So usually you will have significant portal hypertension. That is what causes shunting of blood, and that is where you will get precipitation by constipation. So yes, you are absolutely right. We must use lactulose in patients who have a tendency to constipation in presence of compensated advanced chronic liver disease.
Sir, as we all know that portal vein thrombosis is one of the important causative factor of decompensated cirrhosis, and as high as 25 to 30% of patients with cirrhosis may have underlying portal vein thrombosis. Do you think there is any role of oral anticoagulants like low dose warfarin or something in preventing decompensation in compensated cirrhosis patients?
So there is a very beautiful study by Erica Villa and her group, which demonstrated, they treated almost more than 120 patients in a randomized controlled trial with low molecular heparin for 1 year in the absence of any thrombosis. And they demonstrated that not only they prevented portal vein thrombosis, but there was actually a survival benefit. Now, the benefit of using anticoagulants in patients with cirrhosis is not just prevention of portal vein thrombosis. We know that it is the microthrombi in the liver, sinusoids, that leads to parenchymal extinction, damage of sites, and that is what leads to worsening of the liver cirrhosis. So even that is prevented when you give anticoagulants to these patients. Another new concept which is evolving is something called as lymphatic thrombosis. Now all of you would have seen some patients who have got chylous ascites in the presence of cirrhosis, or a high protein ascites. Protein ascitic protein is 3 grams, 3.5 grams. Very difficult to control ascites. So these patients may have lymphatic thrombosis, and that leads to very difficult management of these patients, where even TIPS sometimes does not work very well. And therefore, there is a very good logic in using anticoagulants in patients with cirrhosis. Unfortunately, we cannot recommend routine use for 2 reasons. One is there is no evidence to show that in multiple trials or in Indian population or anywhere else that routine use improves survival. Second, we are all worried about the complications of these anticoagulants, especially its unpredictability, especially with the use of warfarin. More so for us in Western India, because we have found that 40% of our population has got mutations in the genes which metabolize warfarin. So the VQRC and the CYP2C9, and therefore the variation in the INR is too much with warfarin for us to ask for routine use of these anticoagulants. So therefore, in the absence of robust data, until we can ensure safety of our patients who are taking anticoagulants, we cannot recommend routine use of anticoagulants in patients with cirrhosis. But believe me, 10 years from now, once we are more well equipped, we have better drugs, then we will be using anticoagulants in our patients with cirrhosis. So thank you, very valid question.
Thank you, sir. Thank you, Dr. Akash Shukla, for an excellent talk. I request you again to join at 6:15. I will give you a call for the interesting session of surgical fitness in cirrhosis, role of a physician. Thank you, sir.
Thank you so much again.
Thank you, sir. Our second topic is acute varicose bleed prevention and management. For that, I would like to invite Dr. Gyan Badlani sir, Dr. Tanmay Vyas sir, Dr. Prateen Bhatt sir and Dr. Prakash Vachrajani sir as an honorable chairperson on the stage. The speaker will be invited by the chairperson.
Hello. Good afternoon, everyone. I think this is I must congratulate Dr. Harwani, Yogesh Harwani, for doing this conference for continuous 4 years. I think this was first done when I was the president of APA, and it was conceptualized at that time only. And that was first, and now he has come a long way in doing this 4th Advanced Gastro Summit.
Thank you,
So
sir.
again, once again, congratulations. And our next talk will be given by Dr. Nilla Mehta, and he is a very renowned gastroenterologist of our city, working in Zydus Hospital. And he will be speaking on acute varicose bleeding, its management, and how to prevent this. Nilla bhai, please.
Thank you, sir, for kind words of introduction. At the outset, I thank Yogesh and his team for this excellent conference, excellent scientific program, I must say. I have only one complaint, keeping my talk between two giants of hepatology.
Sir, you are also a giant, sir.
Basically, this is a problem which we face day in and out. We have a huge patient load as far as cirrhosis is concerned, and around 50 to 60% of them would have varices or bleed from varices in his lifetime. So how we define acute variceal bleeding is that it's a bleeding which occurs within 5 days of hospital admission, that is time 0. So if someone bleeds and comes to hospital, so that's time 0, and within 5 days if person bleeds, it's called acute variceal bleed. If the bleeding is significant, meaning that it requires more than 2 units of blood within 24 hours, or patient has hypotension, that is systolic blood pressure less than 100, patient has postural systolic change, that is more than 20 millimeter, or patient has tachycardia, this is a significant bleed. Why it is important to know significant bleed? Because you have to be extremely cautious when you see this sort of bleeding. These patients need admission and many a times in ICU. Once you have treated this patient and they rebleed, suppose I have given patient endotherapy and they rebleed, meaning that they again show some blood in their right tube which was clear, or patient has a drop of hemoglobin around 3 grams, it's called rebleed. It's called treatment failure, and if they bleed after 5 days, it's called rebleed. So how would you know it is variceal bleed? Of course, by doing some investigation. Before you do investigation, what is most important is history. If patient has a history of prior history of chronic liver disease, if patient has a history of alcohol ingestion, if patient has some coagulopathy, you suspect this patient probably has variceal bleed. If patient has stigmata of chronic liver disease, and you know what are the stigmata of chronic liver disease, that is, if that is present, then this patient most likely not all the time, variceal bleed. And of course, you have to ask history of NSAIDs because most of the times they are the trigger factor. And as I told you, when patient comes, you have to examine the patient properly. If patient has hypotension, tachycardia, postural hypotension, you have to be extremely cautious and do this patient's treat accordingly. If patient has shock, meaning this patient has blood loss to the tune of 20 to 25%, this is a massive bleed, patient goes to ICU straight away. Patient has a postural hypotension, the bleed is around anything between 10 to 20%. This patient has a moderate, you have to keep this patient either in the ward or ICU. Or if patient has normal hemodynamic status, this patient has blood loss less than 10%, you can keep this patient in the ward or even sometimes treat patient on OPD base. When a patient comes to you and you've seen the hemodynamic status, the first and foremost thing is resuscitate, especially if they are hemodynamic unstable. This is to be done to preserve tissue perfusion, restore and maintain hemodynamic stability. So patient comes, the most important thing is to have IV access, preferably 2 IV access, preferably 18, not 22 or 24. And if patient is sick, in a shock, a central line would help you out. As I told you, admission to ICU is required if patient has hemodynamic instability, ongoing significant bleeding or comorbidity like cardiac disease. If patient is bleeding massively or patient is in encephalopathy, this is an indication of intubation. Whether to put Ryle's tube, it's a controversial thing. I don't put Ryle's tube. Some people do put Ryle's tube to clear the stomach for subsequent endoscopy. I think blood is the biggest purgative. Patient is having active bleed, it will clear the field. Even if there is blood in the esophagus or stomach, you do an endoscopy and there is an active bleed, most of the times you see the bleeding. Which fluid to give? Normally crystalloids, but if patient is hypotension, sometimes you have to give colloids. When to give PEC, PEC red cells or PRC, if patient has hypotension, unstable vital signs, if there are signs of tissue hypoperfusion, you have to give PCVs. Remember, giving PCV, you have to be cautious. This is a liver disease. You don't have to maintain hemoglobin 9, 10. Young patient, 7 hemoglobin, fine. Don't do anything. Don't keep on putting PCVs. Old patient, cardiac patient, maintain around 8.5 to 9, and that is what you have to do. Only thing is, when patient bleeds, sometimes hemoglobin comes falsely high because of the hemoconcentration. You have to be aware of it. What about platelets? Because many a times these patients have low platelets. You don't have to worry about these platelets. These are chronically depleted platelets. They are functionally normal platelets. V1 with 50,000, this is not a cause of worry. You give platelets only, you've done endotherapy, patient is still bleeding. Ongoing bleed is an indication of giving platelets. Don't keep on giving platelets. The worst thing what we do is, we see a prothrombin time of 2.5 INR and we give FFP. Please avoid giving FFPs. This is a liver disease. You cannot give FFP, 2-3 reasons. One, PT does not tell you the true story in liver disease. High PT does not mean it's a coagulopathy. Number 2, you give FFPs, patient's blood volume, which was intravascular volume, which was low, has gone up again. So the portal pressure goes up again. So the bleeding which had stopped on its own will start again. So don't give FFPs just to control coagulopathy. Cryoprecipitate, not normally, only if fibrinogen is less than 100 and you have ongoing bleeding. Otherwise, you don't have to give cryoprecipitate too. So, and about factor 7, now it's not 10 years back, people used to give it left, right and center, it's not required. Tranexamic acid, not required. Only thing, if patient is on anticoagulant, you have to stop it for momentarily. When to start, nobody knows. But once the bleeding stops, start it as early as possible, as per the indication of the starting of anticoagulant. Most important thing, when you do resuscitation, the most important thing is to give first dose of antibiotic. Antibiotic is number 1 medical therapy in acute variceal bleed. Why? Because when you have varicose bleed, there is a bacterial translocation and patient will go into bacteremia, sepsis and decompensation. So first thing is to give ceftriaxone and that is enough. Early endoscopy within 12 hours, many a times we don't do it. If patient comes at 4, we just observe and this patient has to be taken up within 12 hours. We sometimes give IV erythromycin or metoclopramide to clear, to increase the prokinetic effect and to clear the stomach to see properly. What is the role of vasoactive agent? You know and you are aware of it, terlipressin, somatostatin, octreotide. So how would I choose between them? If I am a physician, patient comes to me with a GI bleed and I want to transfer the patient to some other ICU or some gastroenterologist office, what would I do? I'll give terlipressin. Why? Because you give bolus. You give 2 milligram IV state, fine, and patient is transferred. If you are planning to give it more, then 2 milligram every 4 hours till the bleeding stops, and then 1 milligram every 4 hours. You may go up to 6 hours, but the dose for bleeding is 4 hours. If patient has cardiac problems or patient is old, then what would you do? You give somatostatin. Somatostatin is safe, no cardiac problem. Only problem is it is a very short half-life. So you stop in between, you have to give bolus again. And what is that? 250 microgram. So 250 microgram bolus and 250 followed by 250 microgram every hour. So that has to be given by infusion pump. I usually don't give octreotide, but you can use that too. So old patient, cardiac patient, give somatostatin, transport the patient, give terlipressin. Once everything is done, patient is taken up for endoscopy. So what do you do and what do you see? This is called nipple sign. This is what you see in endoscopy. When you see this nipple sign, what are they? They are platelet fibrin plug. Where do they occur? At the puncture site. When you see that, you know that the bleeding has occurred from the same site. So what do? You bend them. And I don't prefer cyanoacrylate glue in esophagus. Why? Because sometimes or many a times they cause deep ulcers, then patient starts bleeding from those ulcers. And worse, these patients, when they have big ulcers, they get into stricture. So what I do, I usually put bands at the G junction, and then once the blood flow from the G junction is taken care of, I take like this nipple sign into the band and then I just bend them. Many a times, many gastroenterologists, they say when patient is actively bleeding, you can't bend them. That's not true. This is an active bleed. You can see active spotter from here. You can see the spot over here. You can bend them easily. You can see the nipple sign now. This is the sign puncture site from where patient had bled. You can easily bend them. I don't use glue, and I told you the reason. What about fundal varices? So basically gastric varices can be an extension of the esophagus. If they are on the lesser side, they are treated like esophageal varices. If they are on the gastric side, they are treated as fundal varices, isolated fundal varices or isolated gastric varices. What is the difference? As I told you, treatment for esophageal varices is bend ligation. That is the treatment for most of 99% of the esophageal varices. And that is true even for lesser curvature bleed. This is a bleeder, you can see. It is a big bleeder, as you can see over here. And you can bend them easily. So even if it is a gastric varix, but since it is on the lesser curvature side, what you do is you bend them. But if it is on the greater curvature side, as you can see a bleeder over here, this is the bleeder. I don't know why video is stopping and going, but then what you do is just put a glue, and this is a cyanoacrylate glue. Why? Because when glue comes into the contact, it suddenly solidifies and it blocks the varices and it stops the bleeding. So that is the difference between bending and glue. Sometimes the gastric varices are big, and then what I showed you that you can put cyanoacrylate glue is not easy. Because it's such a big thing, this will take 10 to 12 ml of glue. So what do? We do EUS guided therapy. So this is an endoscopic ultrasound, where ultrasound is with the endoscope. And we put coils, which is much safer than doing endoscopic glue. These are the coils coming out. coils cause needles to the blood clot, thrombosis. So we put coils, you can see coils coming out into the fundal varices. We can put 1 coil, 2 coil in this huge fundal varices. I put 4 coils. Once you put coils, you put glue. So glue and coil is the treatment. And you can see the varix has shrunken and there is no bleeding. The most important thing when you do an endoscopic glue in this sort of varices, you put a needle, you take out the needle, patient starts bleeding and the patient can die on table. So please don't do normal glue in this situation, use an US guided. It is effective, as I told you, you can put 1 to 4 coils, you can put glue, a good obliteration, more than 90%, and very effective. It's in fact more effective than normal endoscopic glue. Coil is more effective, as you can see, in recurrent. So basically there was a fundal varix over here, and then there was a recurrence. We put glue and this is what happens. Even there was a negligible fundal varix, we put glue came out of the opening, but it kept on bleeding. You can see white thing which is glue coming out of the varix. But then also patient bled again, and this is how now we are doing endoscopic ultrasound. This is the glue, this is acoustic shadowing, black thing is the acoustic shadowing of the glue, and there was a feeder. So basically this was a feeder, I'll show you. This is a feeder vessel of that varix. So what do? You puncture that vessel, put a coil, as you can see now the coil is coming out, and then you put glue. This cannot be done on endoscopy because you don't see anything what is happening outside. But this can be done with, and now you see there is no flow. So there was a flow and then you put glue and coil, there is no flow. Very effective therapy. If nothing works, then what you can do is putting a sex-taken Blackmore tube and hitch it. I have not put any sex-taken Blackmore tube in last 20 years. Or you can put a stent which is called Ella Dennis stent. Both the things can cause compression of the varix and stops bleeding. Once the bleeding stops, you take it out and then do conventional endotherapy. Again, I have not a single experience of putting these stents. You can control most of the bleeds, almost all the bleeds with endoscopy. Nothing works, then the emergency treatment is TIPS, that is putting a stent between the hepatic vein and portal vein and reducing the portal pressure. You take away the blood supply from the collaterals, and you know that the varices are the collaterals, and that's how you stop the bleeding. When it is indicated, if you can't control the bleed with conventional endoscopy, or if it is a recurrent variceal bleed, or it is a refractive bleed, or now in European country they do preemptive TIPS, means if patient is decompensated and Child-Pugh score less than 14, so not very much decompensated, or HVPG is more than 20, then you do TIPS. We don't do TIPS like that. And we have to avoid TIPS when patient is very sick, meaning Child-Pugh score more than 14, MELD more than 30, or lactate more than 12. You can also do something called balloon-occluded reticuloid BRTO, where you go from the femoral excess, go into the gastrorenal shunt and occlude this gastric varix by putting by inflating balloon and giving sclerosant. Very effective therapy, underutilized, great therapy. The kind of varix I showed you, either you can do US guided therapy or you can do BRTO. The advantage is it can be done even in patients with decompensation. 2-3 slides how to prevent bleeding is, you know, that is HVPG, which is a marker of portal pressure. If it is less than 5, no. Portal hypertension more than 5, portal hypertension more than 10, varices develop more than 12, varices can bleed more than 20 unit TIPS. That's the normal thing. But when we see big varices with red color signs or thinning of overlying mucosa, we know that this patient is going to bleed. How to prevent bleeding? By primary prophylaxis. The mainstay of primary prophylaxis is non-selective beta blocker, and Akash told us that carvedilol is better than propranolol and nadolol. It has more efficacy, it is more tolerable, it has survival benefit. So if patient can afford, thing is to do carvedilol and not beta blocker like propranolol. EVL, Not in Western countries, we do band ligation for primary prophylaxis, but we continue with beta blocker. Gastric varices, the same thing, beta blocker. What is the role of endoscopy? If, as Akash told you, if liver stiffness is less than 20, platelet count more than 150, probably endoscopy is not required. For other cases, you do endoscopy, no varices, then you can repeat it after 2 to 3 years, depending on what is the liver injury. If varices are present and if they are small, you can repeat the endoscopy every year. If they are large, straight away do bending or put patient on beta blocker. Same thing, what Akash told you, if there is now fibroscan has a big role to play. If liver stiffness is more than 25, you don't even have to do endoscopy. This means this is a clinically significant portal hypertension. Just start the patient on beta blocker. If patient has less than 15 and platelet counts are normal, you don't have to do endoscopy. This patient does not need anything. But anything above that, this patient needs beta blocker. Preventing rebleed by non-selective beta blocker and endoscopy. So to summarize, when patient comes with bleed, cirrhotic patient, resuscitate, give antibiotics, give vasoactive agents till you are managing for you are doing endoscopy, early endoscopy. Don't give too much of transfusion, which is called restrictive transfusion method. EVL for esophageal varices, EVL that is band ligation or glue for gastric varices. Rescue therapy is sometimes required. Beta blockers are the mainstay of prophylaxis. Thank you very much.
Thank you very much, sir, for excellently covering basics to advance about variceal bleeding. So if organizers permit, then
We can have
proceed for
two questions, please.
Yeah.
Yes, it's an important topic.
I think the talk was for 50 minutes, the buzzer was at 30 minutes. So,
Sir, what will be your advice to the patient to prevent this bleeding or avoid something like
avoid NSAIDs.
NSAIDs?
Most important, NSAIDs are number one cause of variceal bleed. Otherwise, normal thing, you have to take care of your liver disease. That's the most important thing. But NSAIDs are number one.
Sir, many times in clinical practice for variceal screening, we find large fundic varices without a patient having any signs of bleeding. What's your take on that? Because it's very difficult to make patients and relatives understand what to do further.
Large fundal varices or small fundal varices, don't touch them if they have not bled. I only touch them if there is overlying mucosa is a little bit thinner, there is some color change. There is certain trial where they have done glue, prophylactic glue for large fundal varices. Please don't touch those fundal varices. What you see as a fundal varix is tip of the iceberg. The real varix lies outside. You put glue there, glue cast will happen, it will fall off, you have an ulcer, there is a feeder vessel outside and patient keeps on getting bleed. Don't touch them if they haven't bled.
Last question, please. Mic is off, sir.
Propranolol and carvedilol. Propranolol, you start from low, keep on increasing the dose till the patient's pulse rate is 55 to 60. Literature 55, but anything 55 to 60 is fine. Carvedilol, yes, if you have to stop it or reduce the dose if pulse rate is less than 55. But normally we start with 3.1 to 5 twice a day. We monitor blood pressure. And then if blood pressure allows, we can go up to 12.5 a day, max.
So 12.5 BID
And
should
of course,
be the
you
right.
guys give more. I've seen your prescription. You guys give a lot more than what we give.
Thank you. Thank you.
Yeah, the reason is absolutely, indication is different. But the thing is, we don't have to worry about it, even if the dose is more.
Yeah, thank you very much. Yeah.
Thank you, sir.
Thank you, sir. Third topic is management of acute kidney injury, AKI and cirrhosis. For that, I would like to invite Dr. Radhika Chavan ma'am, Dr. Saureen Dalal sir, Dr. Mustafa Rangwala and Dr. Tejas Modi sir as a chairperson on the stage. The speaker will be invited by the chairperson.
Actually, this is a brainchild and initiative of noble people of Ahmedabad and Dr. Yogesh Harwani. And I really thank you for giving me the position of a chair at your session. And now we are going ahead with the lecture of the day by none other than Dr. Shiv Sareen, who happens to be the hepatologist not only of India, but the globe over. Whenever we encounter a liver disease, something would strike us, that Pilla Sahib Shukar Share. And everybody would think of Dr. Shiv Sareen, be it a gastroenterologist or be it a physician. And so he's talking about management of acute kidney injury in cirrhosis. Over to Dr. Shiv Sareen, please.
Greetings from the Institute of Liver and Biliary Sciences. I'm very thankful to Dr. Yogesh for having invited me for this important meeting. I wish I was there with all of you in person, maybe next time. I have nothing to disclose. I would try and cover the topic into few heads. The relevance of AKI in patients with cirrhosis has to be appreciated in this very important study. The in-hospital mortality is having 8 times higher odds ratio of those who have AKI versus no AKI. 30-day mortality is about 9 to 10-fold higher. Same is true for 90-day and it doubles up at 1 year. So kidney injury in a cirrhotic is sinister. It could be functional or structural. Functional could be volume responsive, which is generally pre-renal or sepsis-induced AKI, while non-responsive is HRS AKI. Let's look at the new definitions. HRS1, which was acute 2 weeks duration, now is HRS AKI and is abbreviated to 48 hours. Absolute increase in create of more than or equal to 3 milligrams within 48 hours, or important, this is new, urinary output is less than or equal to 5 ml per kilogram in 6 hours. So you can actually define in 6 hours AKI. Or percentage increase in serum create of equal to more than 50% of the last 3 months data. This is HRS type 1 or HRS AKI. Now HRS type 2 earlier, now is HRS non-AKI. It is slow. It has 2 types, HRS with acute kidney disease, HRS with chronic kidney disease. eGFR is low to less than 60 ml per minute in the absence of structural causes. This is less than 3 months. Or percentage increase in serum create of less than 50%. Here it was more than during the last 3 months time. And if it is HRS CKD, it means it is lasting for more than 3 months. This is to show you how urine output decreases in a period of 7 days time. Here progressive or persistent AKI. So the urine output gradually comes down to 10 or 20 ml, while in those where there is no AKI or AKI has happened and improved, you maintain 35 to 40 ml urine in these patients. Now stages. Stage 1, 2 and 3 as per Akin are well known to you, create of more than equal to 3 milligram rise, or serum create increases to more than 1.5 or doubles up. or there is an increase of more than twofold to threefold. So this is stage 2, rapidly rising, and stage 3, where it is more than threefold or create has become more than 4. So please remember all these. Now progression. Progression is stage 1 to 2 or 3, regression is 3 to 2 or 1, and treatment response, full response is where return of serum create to value within less than 3 milligram of the baseline value. Now this spectrum, we have to differentiate the injury. Is it of the glomerulus, tubule, interstitium, blood vessels, and differentiate. So first and simple, which we often forget, is a urine analysis. Look for epithelial cells, hyaline cells in microscopy. And color, is it turbid or non-turbid? Turbid will suggest it's an injury maybe of the tubules. Let's look at HRS versus ATN. You have a patient of cirrhosis who came with shock, maybe ATN. Non-responsive, urinary sodium is high, it is retaining. FENA, fractional excretion of sodium is more than 1. Osmolarity is more than 350. And granular casts are present here. You can see that renal tubular epithelial cells, and you also have granular cast. This is ATN. Here it is AKI, HRS. You don't see any of these granular casts or RB. Now, HRS microscopic view, you can, as I previously showed, is quite clear. And HRS, AKI, ATN, you can see bilirubin crystals, extremely important, and renal tubular epithelial cell cast, which are also seen. Muddy brown granular cast, these are very important to differentiate and diagnose. Now, there is a term called cholemic nephrosis, especially in ACLF. So, there is a bilirubin of 20, and you have kidneys which are packing up. In this, you will see bile cast and renal tubular epithelial cells. So, cholemic nephrosis. Then, you also can see in some of these coarse granular casts, muddy brown casts. So, urine examination and training your biochemists or the lab people is very important for this. We normally do FENA, but an important hepatology paper showed fractional excretion of urea can be helpful. Urine urea divided by serum urea, urine creatinine divided by plasma creatinine multiplied by 100. And this has a very high sensitivity and specificity, and cutoff is 33% or so. Remember, try and establish in your labs. The pathophysiology of hepatorenal and AKI has gone a sea change in the recent 2 years or so. All of us are aware of the Schreyer's hypothesis of vasodilation. We also know that because of this effective arterial volume, stimulation of RAS system, and compensatory increase in cardiac output. This is very well known. Recently, it has also become known that inflammation, bacterial translocation, renal hypoperfusion because of vasoconstriction, post-renal tubules and the blood vessels have high resistivity index, but earlier it is not. So the kidney gets less amount of blood. This intrarenal inflammation and microvascular changes are the cause. One more thing which is missing in that diagram, and I want to emphasize, is the sterile inflammation. This is the damage, death of liver cells in alcoholic hepatitis, drug-induced liver injury. This sterile inflammation, cell death, leads to activation of innate immune system and can lead to inflammatory response, which can come back to the kidney. So, inflammatory response due to bacteria, and due to the death of cells, inflammatory response. So patients who have got maybe more jaundice, more severe liver injury, alcoholic hepatitis, kidneys are bound to get affected. Are there biomarkers? There are some cystatin C which we regularly use. It is a biomarker for natural course of renal functions in patients with cirrhosis. It is very good marker. Anything above 1.5, you should start worrying. NGAL, which is neutrophil gelatinase associated lipocalin. It's a good marker of the damage of loop of Henle in collecting ducts, and it is representative of leukocyte damage, and it increases in up to 12 hours time. Similarly, another factor which we often use is IL-18, which is a marker of monocyte, macrophage, epithelial and dendritic cell, inflammatory markers, and this also starts increasing. But none of these markers is actually diagnostic. We still use serum create. This is to show you ATN, and this beautiful paper tells us two things. If FeNA is low, less than 0.1, urinary albumin is high, or IL-18 is high, and NGAL is about 365, you can differentiate ATN from other causes of injury like pre-renal or AKI due to sepsis and others. I'll now jump to the management algorithm. This is the International Club of Ascites. Patients who have got stage 1 AKI, only 0.3 milligram rise in create, monitor. Don't start immediately albumin. Just withdraw nephrotoxic drugs and wait with fluid resuscitation. And if it is progressive, then you have to go further. Otherwise, you have to observe these patients. Now, stage 2 and 3, you have to withdraw diuretics already, and now you start giving albumin. Then, if there is a response, it's okay. If there is no response, it meets the criteria of HRS, then you may add vasoconstrictors to albumin. Pre-renal is because of shock or hypertension. You can give albumin, crystalloids. I'll show you some data. In patients with cirrhosis, this is our FRISC protocol. FRISC protocol is fluid resuscitation in septic patients with cirrhosis and hypotension. Here, giving albumin in 2 hours time, 5% albumin, it increased compared to saline. Urine output was not changed, but 4% increased total. But what it resulted into is a reduction in the lactate, and the survival benefit was there up to day 6. So we now use albumin 5% as the first fluid in patients for pre-renal. Can 20% albumin be better? This recently published data from Dr. Rakhi and our group shows that giving 20% albumin, there is faster improvement in MAP, faster decline in lactate, less need of dialysis, higher time for dialysis initiation. However, survival did not improve. Also, worse enough was pulmonary complications were seen in about 22% of the patients. So we gave 20% albumin for first 3 hours in patients who are not likely to improve with 5%. How do you monitor your patient has not gone into hypervolemia, lung complications and others? It's easy to do a extravascular lung volume. You can put in a catheter in that, and there are machines now. Most of them can give you extravascular lung volume, which should be 5 to 7 ml. The moment it is 8, your lungs are flooded. Alternatively, a good clinician can do lung ultrasound in that, which can detect increases of 10 to 20%. Remember, abdomen grade 3 ascites or SBP is a compartment syndrome, and the pressures are generally 20 and above, while normal is just 12. So in those patients, don't give extra fluid, rather give negative fluid and do modest volume, not large volume, 3 liters or so. It will improve perfusion and improve creatinine. So we have given albumin into the right patient, but it doesn't work. So now we have to add vasoconstrictors. Now here is the importance of mean arterial pressure. If you have given a drug and mean arterial pressure improves Suppose it was low and it has improved by 15 millimeter, 10 millimeter, the serum creatinine levels will come down. So better is the improvement in MAP. Suppose the MAP does not improve, rather decreases, then the creatinine levels will keep going up. What are the vasoconstrictors? Terlipressin, 1 milligram, you can go up onto this to 2, 3, 4, maximum 12, but don't go above 4 milligram per day. And it will decrease serum creat, and you can give it, should give it as a continuous infusion. NORAP is also a good 0.5 to 3 milligram titrate to achieve 10 mm rise in mean arterial pressure, continuous. Midodrine 5 to 15 milligram 3 times, or octreotide 100 to 200 microgram, preferably as continuous infusion. Now let's look at ACLF. Earlier was cirrhosis. Now we are entering into a difficult group of patients, ACLF. Now this paper shows, compared to acute decompensation in cirrhosis, a patient with ACLF, jaundice, ascites, coagulopathy. In these patients, HRS may not be different, but response to volume is low and the structural damage is much more. This study by Ankur from our group showed that terlipressin response versus no response. The survival is much better those who responded. But who responded? Only 1 in 3 respond. This study by Vinod, also from our group, Dr. Arora, it showed that if the patient responds to therapy, he is better. So responders do much better than non-responders. Here, compared to noradrenaline, terlipressin was far better at day 4, at day 7, and day 14. However, you will notice that 2/3 of the patients still require RRT by day 4. So it's a very rapidly aggressive disease. Those who have high MELD and HE have poor response. Turley has a problem of side effects in about 1 to 2 in 10. Who are not going to respond and who are going to respond? If there is a lower create, lower MELD, and there is a pressure response that MAP goes up, then 3 days of terlipressin, not 1 or 2 days, will show response. Now comes the group which is difficult, non-responders. I told you 35 to 50% may respond. The non-response could be your diagnosis is wrong, it is ATN, or you are too late in diagnosing, or the patient has a cardiac problem, he's not pumping enough, or there is systemic inflammation very intense or a shock. Now, can AKI predispose to further AKIs? This study, very interestingly, this is the first episode of AKI. You may have good 1 year, cumulative hazard is about 0.5, 0.4. But if you have 1 episode, 2 episodes of AKI, repeated AKIs, then these patients have worse outcome. Hazards increase twofold, 1.5. Next is AKI in cirrhosis predisposes to CKD very fast because of the cytokines and the sterile or non-sterile inflammation. So the kidney is inflamed. The tubules are injured and they are unable to repair. Vascular changes occur. Interstitial, perivascular fibrosis rapidly develops and CKD develops if prolonged AKI is there. Now, those who do not respond, how do you manage? Options are MARS, plasma exchange, CRRT, and hemoadsorption. Now, the data on MARS, there are several studies, but the largest trials of Benares or Girth show that there is no improvement in the 28-day mortality. Initially, you may have some improvement, but not 21 or 28-day benefit. So it's an expensive, probably not an effective therapy. Can plasma exchange help? Yes, it can reduce your liver failure related mortality. Here, standard medical therapy, plasma exchange, and here it is FPSA, this is SMT and plasma exchange. So you can see that patients who have got plasma exchange have a beneficial effect compared to other therapies. But overall survival did not improve. This is an algorithmic slide. Patient has come with acute kidney injury. Then you will decide whether it is pre-renal or it is structural. Structural, you have to do like ATN or something, you have to do accordingly. If it is pre-renal, our first, whichever stage is to give volume, withdraw diuretics, and if needed, after 48 hours, albumin. Closely monitor these patients. If they are volume responsive, very good, then keep monitoring. If they are not volume responsive, which may be in about 60-65% or so, then you will have to start vasoconstrictors. You give vasoconstrictors, if they respond, very good. If they do not respond to vasopressors, you have to assess for other therapies, including renal replacement or liver transplant or palliative care. Now HRS non-AKI, which is entirely different, which is long, it is type 2 HRS, now called HRS non-AKI. TIPS is the best option for such patients. This meta-analysis shows of 7 studies that patients who receive TIPS, urinary sodium excretion improves and serum creatinine levels over a period of time decrease, and patient survival is far better. So you have now improved creatinine and you have improved the overload. My last slide is to show you some messages in this difficult to treat patients. First, AKI in cirrhosis is common, and if it is high, stage 2 or 3, hospital mortality is 8 times, and 30-day mortality could be 9 to 10 times higher. Diagnose HRS AKI, incorporate urine output to get a 6-hour diagnosis. You must examine urine, exclude ATN, cholemic nephropathy, and then just see that it is HRS. Terlipressin as a continuous infusion should be used after albumin therapy has been given. Noradrenaline may be as effective in cirrhosis as terlipressin, but not in ACLF. The only drug is terlipressin. Midodrine and use of this drug from 2.5 to 15 milligrams 2 to 3 times a day can be tried in HRS non-AKI, and the MAP should increase by 10. It takes about 4 hours to be effective. We don't have good biomarkers. We need non-responders to treatment have very poor outcome. HRS AKI in ACLF needs a different aggressive monitoring and assess for underlying acute kidney disease or CKD. HRS non-AKI, type 2 HRS of the past, early tips and liver transplant could be options. I hope we all can make kidneys safer by not doing a CT scan when the patient comes to the emergency. Please do not use analgesics or contrast in a cirrhotic without justification. Thank you for your kind attention and all the best.
Good evening, sir.
Good evening.
Your mic.
Very nice presentation, sir. I have one question for you. In a patient with a HRS type 2 or HRS NACI and decompensated CLD, can we give beta blocker? Can we continue beta blocker?
One of the problems remains is of the low blood pressure or MAP. Combination of midodrine plus beta blockers can be tried. We have done as part of a thesis. So as long as MAP is about 70, 75, you can use beta blocker. This will be especially useful for high risk decompensated cirrhosis patients who cannot go for EBL. So you give beta blockers but add midodrine.
Sauri,
questions from the floor? Dr. Yogesh?
Any questions?
So I think your words were a gospel for us as far as liver and biliary system are concerned. We really thank you for being online, sir, and a huge round of applause for boss, sir.
Thank you. All the best.
Thank you, sir. Thank you so much, sir. Thank you, chairpersons.
Now it's time for a debate. Third topic is alcoholic patients with acute and chronic liver failure. I would like to invite for that Dr. Tanmay Vyas sir, Dr. Pathik Parikh sir, Dr. Nihal Sadhu sir and Dr. Chirag Desai sir as a chairperson.
I would request Dr. Chirag Desai to introduce the speaker and also narrate the importance of this debate. Dr. Chirag Desai, sir, please introduce the speakers and also narrate the importance of this debate, sir.
So, thank you, Yogesh, and congratulations for your yearly events. The next session is acute on chronic in alcoholic patients, and whether we should manage them conservatively or transplant should be done early. Now, this is the day-to-day dilemma in ICUs when a patient, alcoholic liver disease patient is admitted with acute on chronic presentation, and too early or too late, the futile transplants, and best outcomes, which are the patients, what is the right time to prime this family for the transplant. These all are very important issues, and for that we have got very good speakers today. And first I call upon Dr. Jamwal from Delhi, and he is from Medanta Hospital.
No, sir.
Sorry.
Artemis, sir.
Artemis. He is from Artemis Hospital, and he is going to defend the conservative aspect.
Thank you, sir, and good evening. So at the outset, I'd like to say that it's not a debate. Basically, it's a teamwork. So management of ACLF is a teamwork. We cannot debate because we both are surgeons and the physicians are for betterment of patient. This is not that medicine is better or transplant is better. At the outset, I will say that the transplant is the standard of care at the moment, and it should be offered to patient who's suitable for in any ACLF. Especially ACLF, there are some problems that we will be discussing. So I have no conflict of interest. And at the first slide is like, what is the epidemiology of alcoholic liver disease? This is one of the surveys which are done in hepatology, and I feel the epidemiology is much higher. So if we see the total alcohol use is around 2.4 billion people in the world, and around 280 to 370 million people have alcohol use disorder, and out of them around 23.6 million people have compensated cirrhosis, and 2.4 million people develop decompensed cirrhosis, but I feel it's much higher. So it's a very common problem, and all of us are seeing patients regularly. 50% of patients in India mostly have alcoholic liver disease. So I will present with 3 case scenarios. The first case is a 34-year-old male, chronic alcoholic. His last intake was 1 week back and presented with recent onset jaundice and ascites of 3 weeks duration. Problem was progressive bilirubinemia increase and presented with grade 1 to 2 HE. So his parameters are below. His bilirubin was 23, INR was 2.3, creatinine was 1.3, grade 2 HE, and MELD sodium was 31 at admission. So at admission, medical management was started. He was counseled for liver transplant, and on day 7, developed worsening AKI, jaundice, and HE. He was recounseled for liver transplant. I will tell what was the further outcome. This is another case, 44-year-old male, chronic alcoholic, last intake was 8 weeks back, recent onset jaundice of 3 weeks. He had a progressive decreased urinary output. His bilirubin was 9, INR was 3.3, creatinine was 3, and his MELD was 39. So at admission, similar medical management, counsel for liver transplant. On day 7, he started developing worsening of jaundice. He developed AKI, respiratory distress, recounseled for liver transplant, and we'll discuss further. And another who presented with 4-week duration of last intake of alcohol, recent onset jaundice and ascites, progressive bilirubin increase, presented with decreased urinary output, HE and shock. So his bilirubin was 14, INR was 2.9, serum creatinine at presentation was 4.2 with grade 2 HE, and MELD sodium was 40. So similar, he was started with medical management, counseled for liver transplant. So we'll discuss what issues were there. So he developed worsening jaundice, AKI, respiratory distress. On medical management, shock improved and his HE showed improving trend. So he was also counseled for liver transplant. So as I told earlier that transplant is the standard of care for liver, ACLF as such, despite of all etiologies. But do all ACLF require transplant? No, because mild and which patients show improvement, they do not require transplant as an option. And do all eligible for transplant require transplant? The answer is no, because people who present with or patients who present with sepsis or multi-system organ failure at the presentation may not or not eligible for transplant. And do all eligible and who require transplant receive transplant? That is no, because of various issues, contraindications to liver transplant, financial issues, and non-availability of donor in patients who present with alcoholic ACLF. That's why. So there is a shortage of organs and other financial issues which are associated with our people. So you will be listening to these two terms. One is on the left side, this is a EASL-CLIF consortium, and on the extreme right is a Asia-Pacific consortium. So EASL, these basically are the liver failure scores which most of the countries in Europe and in Asia-Pacific use it. So EASL-CLIF, the difference is that the score depends on extrahepatic organ failure. So the scoring is based on whether kidney failure, there is shock, respiratory distress, or organ failures, whereas the Asia-Pacific score is basically purely on liver failure. And now with the addition of ARC, it has introduced ARC score also. So the difference is that the hypothesis is that the liver failure developed first, and later on by 1 or 2 weeks the extrahepatic organ failure started developing. So the APASL concept is that there is a window period of 1 to 2 weeks before the development of organ failures. So this window period could be used for therapies, improvement, or use of liver transplant. Once the transplant organ or the extrahepatic organ starts developing or the complications start developing, at that time transplants become futile. So this concept of APASL, that the window period is very important, which is still being debated, being adopted by APASLs, but others are still not very agreeing with it. So what is the pathophysiology of ACLF, what we are discussing? So the pathophysiology of ACLF is a systemic inflammatory response syndrome. As you can see on the right side of the picture, the baseline or the major part is SIRS. So either patient presents with two phenomena, either he develops a hyperinflammation, that patient develops features of hyperinflammation, or he develops an immunoparesis. Immunoparesis means patient develops shock, sepsis, other problems, and hyperinflation that develops organ failures, and this is related to intestinal dysbiosis, increased gut permeability, and portal hypertension, in addition to ongoing liver damage. So all this leads to organ failures, mortality, or there is spontaneous recovery. So SIRS is the most important component which drives this ACLF. And why we are discussing why the normal ACLF is different from the decompensated cirrhosis. In the right picture you can see, if the liver is normal, suddenly the liver gets an injury, and the blue is a normal liver which develops ACLF, and you can see that the graph of ACLF suddenly shifts down. So if some intervention is done at this stage before it goes into multi-organ failure, there is chance of that patient or the liver may develop spontaneous recovery without developing extra organ failures. Whereas the patient with decompensated cirrhosis, if he or she gets a injury, so the chances of recovery are less, and the the decline is also less. So because ACLF is different because it has a very high short-term mortality, 30 to 40% within first month. It mimics acute liver failure, and multi-organ failure is very common as compared to a decompensated cirrhosis, and the intervention window is very small when compared to a decompensated cirrhosis. So that's why we are discussing about the timeline in ACLF. And management depends upon the initial 4 weeks, that what can be done, then the intermediate, the patient response, and long term. So this is without transplant, what management can be done. So why some alcoholic patients are not a candidate for liver transplant? So if the patient presents with multiple organ failures at the time of presentation, that patient may not be a candidate for liver transplant. There is no identified eligible donor in the family. So that time, because it is mostly a LDLT program, so no identified donor. The contraindications present to the liver transplant at the time of admission. There are financial constraints and active alcohol intake. I think that my surgical colleague will touch what is the data and what is there, what is the recent on active alcohol intake. And this was a survey which was when I was a part of LBS. So we can see that the ACLF cohort of 90-day survival is, if they have present with all the features, have a very high mortality of 50% at 90 days. So ACLF as such has a very high mortality. It should be taken seriously. That's why these things are there. And despite doing a transplant in a ACLF, if we see the Cliff SOFA studies, if 1/3 of patients receive liver transplant in ACLF 2 and 3 when the organ failure already started. So at that time, the outcome is very poor despite patient undergoing a liver transplant. And in Indian scenario, we have less accessible to liver transplant in ACLF organ 2 or 3 damage. So we have less data as compared to them. And we have to opt for a non-transplant option in such conditions. So alcoholic ACLF, the treatment basket considers one, the standard of care is nutrition. Nutrition is very important, and in severe alcoholic study, hepatitis study, they have showed that the recovery is comparable to use of steroid. The most important component, as previously, was corticosteroids, but the drawback is only 30 to 40% of patients show response in a selected group. The 60% patient have no response, and there's no added benefit beyond 1 month of use of steroids. And the definite option is liver transplant, but patients who don't have option of liver transplant or cannot afford liver transplant, what are the options? So options are whether we use rescue therapy like drugs, standard of care drugs, we use bridging therapy like plasma exchange, or we do experimental therapies or the neotherapies like a fecal microbiota transplant that I'll be discussing. So nutrition therapy is very important because so my talks of medical management will be based on this, that one is nutrition therapy, steroids, plasma exchange, fecal microbiota transplant, and regenerative therapy in addition to standard medical therapy. So nutrition is important because if we see the classic Mendel study which was done in 1995, and this was done in severe alcoholic hepatitis, and if we see patients who were given more than 3,000 kilocalories per day, when compared to patients who were given less than 1,000 kilocalories, there was a lot of difference in survival. So patients who had a low calorie intake were a high mortality as compared to patients who had a very high calorie intake. So nutrition is not just a supplement, it's a part of therapy in patients with severe alcoholic hepatitis as well as alcoholic ACLF. So how does nutrition work? Because it causes liver regeneration and prevents hypoglycemia. It maintains positive nitrogen balance. It decreases the ammonia production and improves quality of life and survival. So this is how nutrition works. And this is steroids. Steroids are composed to be a very important component of the alcoholic ACLF and severe alcoholic hepatitis. But the problem in using steroid is that 25% of patients, when they are present at the start of therapy, have infection, so they cannot be given. And new infection develops in around 25% of patients when they are giving steroids. And mortality beyond 1 month is very high. So it doesn't change the mortality beyond 1 month. So steroids have benefit up to 1 month. So steroids may not be that in all, but patients who were given steroids as compared to non-responder, this was a classical Lille model, and it showed that the benefit was non-respondent had a very high mortality. So steroids are still considered to be important component of therapy, but only 30 to 40% are responders. So can we develop a test or something which can decide responders and non-responders from the baseline? So there was a study which was done in ILBS when I was also there. So they did a urine metabolome. And in a urine metabolome, if the acyl carnitine is very high, if more than 1000 microgram, so then these patients can detect who are non-responders and they have very high mortality. So we can predict from a simple urine test whether the patient will respond to steroids or not. Second is role of plasma exchange. So plasma exchange basically in ACLF uses a low volume, that means 0.5, half volume of plasma is exchanged. It with low steroids helps in improvement of ACLF. So this study was done in CMC Vellore, and they have compared it to standard medical treatment arm, and we can see that the two groups were comparable, and at the end of around 3 months, the survival in the ACLF group, alcoholic ACLF group, was superior as compared to patients who were receiving standard medical therapy. So the concept is that the Plex will take care of the immunomarkers, it will take care of the bilirubin, it will take care of toxins from the blood, which increases SIRS as well as other organ failures. The second treatment, which is fecal microbiota transplant. So I was the part of the study which did the first. We did the first fecal microbiota transplant in severe alcoholic hepatitis. So in these patients, we did patients who were ineligible for steroid or they were non-responders. In those patients, we used fecal microbiota transplant through the NJ tube for 6-7 days. And we saw that there was improvement in the overall survival, there was improvement in baseline bilirubin, there was improvement in MELD score, and the survival improved. So, and this metabolome of the stool persisted for more than 90 days. And this was further verified by a study which was published last year from PGI Chandigarh. In these cases, they have randomized patients with severe alcoholic hepatitis with ACLF in two arms. One is standard arm and fecal microbiota transplant arm, and they gave 1 dose of fecal microbiota transplant at the baseline and followed them for 6 months. They showed that the survival curve was better in patients who received fecal microbiota transplant as compared to patients who had standard treatment. And recently, last week, this study was published from ILBS only, in which they have randomized patients between steroids and fecal microbiota transplant. Initially, I was part of the study. Later on, I moved out. So this also showed the benefit of fecal microbiota transplant, which sustained over around 6 months to 1 year. So fecal microbiota transplant, as a concept, improves the gut translocation, it decreases the portal pressure, and improves the stellate cells. That's why it improves the overall survival. And the last part is regeneration. So beyond 3 months, what will happen to liver, which has already improved? So there's a concept that the regeneration therapy. That
Total Kapil, you have already exceeded time.
Yeah, that's last slide only.
Okay, fine.
So if we use a regeneration therapy like GCSF, which will promote regeneration through mobilization of the cells from bone marrow as well as stimulate the hepatic progenitor cells, it will regeneration of the liver. So this study, which was a randomized controlled trial published in 2019, showed that there was a benefit of more than 2 times of patients who received GCSF therapy as compared to patients who received standard care of therapy. So what happened to our patients? So this is first patient who had developed a MELD of 31. So he underwent 3 sessions of Plex. His MELD at 4 weeks improved to 23. His MELD at 24 weeks to 20, and he survived. The second patient, he received FMT. We gave him 7 sessions of FMT, and he also survived. The third patient, because of his already organ failure, he received SLED and SCUF 7 sessions, and he expired. So how should we manage such patients? So suppose the patient comes with ACLF or MELD more than 20. If the patient does not have extrahepatic organ failures, so in such patient we should try standard medical therapy in addition to either steroids, fecal microbiota transplant, or Plex, and reassess at 7 days. If patient is improving, then we should continue same treatment and plan for regenerative therapy in future. If the patient has worsening and is suitable candidate for transplant, this patient should go for transplant. If the patient has extrahepatic organ failures at the time of admission, we should give supportive therapy, maybe giving plasma exchange, and reassess at day 7. If patient shows improvement and is candidate for transplant, patient should be subjected to transplant. And if patient is worsening, then we should prognosticate the family continue supportive therapy and wait for therapeutic window if available. So my last slide is that ACLF is a dynamic clinical condition with very high mortality. Liver transplant is the present standard of care for eligible alcoholic ACLFs. Nutrition is very important treatment for ACLF and severe alcoholic hepatitis. Steroid reduces 1 month mortality but is in a selected group with associated complications and does not have a long-term benefit. Plasma exchange has a short and medium-term benefits. FMT is an upcoming treatment modality with both short-term and long-term benefit but in a selected group of patients. And regenerative therapy with growth factors helps in long-term benefits of such patients.
Thank you, Dr. Kapil. So we can have questions together. Vaibhav Sutaria. Surgical by Dr. Vaibhav Sutaria.
I think the next talk is by Dr. Yogesh Harwani, and he is going to talk about the role of liver transplant in this situation, and then we'll have a common questions.
Alcoholic liver disease patients, they present to liver transplant unit either with severe alcoholic hepatitis, acute on chronic liver failure, or acute decompensation of stable liver cirrhosis. Alcoholic hepatitis is a distinct clinical syndrome among individuals with chronic and active harmful alcohol consumption for a period of past 6 months. Patient presents with jaundice, a serum bilirubin of more than 3, elevated AST, ALT ratio of 1.5, and no other obvious cause of hepatitis. Alcoholic hepatitis is associated with a very high mortality, chance of death of up to 30% over a period of 1 month. Now, alcoholic hepatitis patients are very likely to develop alcoholic acute on chronic liver failure. These patients may decompensate in the form of ascites and or encephalopathy. And patients of alcoholic hepatitis, when they develop acute or chronic liver failure, they develop systemic inflammatory response syndrome and immune imbalance. The most probable hypothesis for this etiology is release of cytokines from inflamed liver, leading to systemic disturbances. And the extrahepatic organ failure which happens in ACLF is most probably secondary to these cytokines. Now, in such situation, patients are at a very high risk of secondary bacterial infection, and they are associated with a very high 28 days mortality. So, on the medical management part, steroids are the only pharmacological options for patients with severe alcoholic hepatitis and alcoholic ACLF patient, and they are recommended by major international societies as first-line treatment. However, use of these drugs is limited by the potential adverse effect and unpredictable benefit in 40 to 60% of the cases. Now, probability of response to steroids is further lower in patients with ACLF compared to those with alcoholic hepatitis without ACLF. And probability of response even further decreases with increasing grade of ACLF. Now, ratio for liver transplant in alcoholic hepatitis. Actually, the consideration for alcoholic liver transplant for alcoholic hepatitis came into thought in 1995 when the explant pathologies of transplanted liver, the graft liver, were examined, and the patients who were having alcohol relapse, they were having higher survival compared to the patients who were having abstinent from alcohol. And this led to a concept, this led to many retrospective study which reconfirm that the patients when subjected to liver transplant, they are having similar survival whether patient is having alcoholic hepatitis, alcoholic ACLF, or alcoholic decompensated liver cirrhosis. And now 6 months rule. In absence of, these patients, the problem with liver transplant is when these patients present to liver transplant unit, they are drinking right before just their presentation. And most of the transplant center, they require minimum 6 months abstinence rule even before considering transplant evaluation. Due to shortage of organ and concern for alcohol, relapse to alcohol use, liver transplant has remained controversial for severe alcoholic hepatitis. Now, the 6 months rule actually has been brought to allow the liver to improve and regenerate. However, the 6 months criterion has been taken as a rule not to evaluate patient and not to list the patient. So, of the various predictor of relapse to alcohol use after liver transplant, 6 months rule is one of the weak predictor. The better predictor of relapse are younger age, family history of alcohol use, and patient psychological status. In a this is the study which I was talking about, in that 2009 patients with alcohol associated liver disease, including patients with alcoholic hepatitis. They have retrospectively analyzed and they found that the rate of acute rejection and chronic rejection were higher in the patients who remained abstinent compared to the patients who relapsed to alcohol use. The 4 retrospective studies have shown similar survival after LT, irrespective of abstinence period after transplant. So this has led to one prospective case control study in France, where they challenged this 6 months abstinence rule. And in that study, selected 26 patients who met the diagnostic criteria for severe alcoholic hepatitis and who did not respond to steroid therapy received liver transplant. And the outcomes were compared to patients, matched 26 patients with severe alcoholic hepatitis who had not undergone liver transplant. And the 1 year survival they found was 1 year survival of 77% in patients who who underwent liver transplant, compared to 23% in patients who did not undergo liver transplant. Among these 26 patients, 2 patients reported relapse to alcohol use and only 1 reported relapse to heavy drinking at 2-year follow-up. A recent retrospective analysis of UNIS comparing survival after LT for patients with alcoholic cirrhosis and severe alcoholic hepatitis showed similar 5-year patient survival and 5-year graft survival. So data from these data have been reconfirmed by the retrospective analysis from the surveys of different transplant centers in US, and they revealed a survival of 74%, 88% and 100% at 6 months. Yet another retrospective analysis, 147 patients, when they received early liver transplant without meeting 6 months abstinence rule, the transplantation survival was 94% at 1 year and 84% at 3 years. However, 10% patients at 1 year and 17% patients at 3 years, they reported relapse to alcohol use. Now, in a meta-analysis of Innervan study evaluating role of liver transplant in alcoholic hepatitis, the authors showed 1 year survival of 85% with no difference compared to patients transplanted for alcoholic cirrhosis with 6 months abstinence. And above that, 16 folds increased survival to alcoholic hepatitis patients who have not undergone transplant. Further, the relapse to alcohol consumption in this analysis was 14% at 2 years to what is observed, and which is similar to which is observed in patients who are being transplanted for decompensated alcoholic cirrhosis. So based on this encouraging data, early liver transplantation is recommended for patients with severe alcoholic hepatitis, provided the selection criteria are met. So, severe alcoholic hepatitis is characterized by acute and rapid decompensation. So, early identification of patients with a high likelihood of success after liver transplantation is very important. And MDF score and Lilly score are having a higher prediction for mortality in patients with severe alcoholic hepatitis. So, 2 factors are to be kept in mind while selecting patients for severe alcoholic hepatitis: those who are likely to die without transplant and those who are likely to remain abstinent. About 25% of those non-responsive to steroid therapy will recover with medical management alone, and if transplanted early would divert a liver that could have otherwise been used for an alternative candidate. And if they are predisposed to LDLD, they may pose the donor to a risk. Risk of relapse to alcohol use after transplant for patients with alcoholic hepatitis is a genuine concern, as long-term outcome of patients who engage in harmful alcohol use after liver transplant is reduced to compare to patients who remain abstinent. So there have been various models have been tried to evaluate, but in a recent, currently one prospective study from Europe, they suggested selection criteria for liver transplant in severe alcoholic hepatitis. And the criteria are the patient should have a first episode of hepatic decompensation and alcoholic hepatitis in this index admission, severe alcoholic hepatitis non-responsive to steroid therapy, excellent psychosocial status as agreed upon by everyone in the primary team, nurse, social worker and surgeon. And the signed document by the recipient for alcohol rehabilitation if it is indicated by the psychological team. However, the patients with alcoholic ACLF and alcoholic hepatitis, they do need transplant, but there is a big controversy regarding the priority in cadaver organ allocation. Patients with mild alcoholic cirrhosis with decompensated CLD having a MALD of 25 and ACLF grade 3 patient, ACLF grade 3 patient with a MALD of 25 is having a higher 14 days mortality compared to a cirrhotic patient with a MALD of 35. Various retrospective studies have reconfirmed the effect of liver transplant in giving survival to patients with alcoholic ACLF, and amongst few the survival at 1 year in this study ranged from 52% to 93%. However, the study which shows survival of 52%, almost all of the patients in their study was ACLF grade 3. Now recently published study from India, from liver transplant registry, they revealed 1 year survival after liver transplantation for ACLF grade 1, grade 2 and grade 3 is 95.6%, 85.4% and 75.6%. And in that study they reported that ACLF grade 3 patients who are not receiving liver transplant, they have a survival of only 5.9%. And one additional thing that ACLF patient having underlying cirrhosis, even though when they improve for a short term, and in a long term at a 6 months, these patients go on to develop further deterioration in their ACLF grade and a mortality of 40% approaches. Now these patients, ACLF patients, are when transplanted, they are having a very high risk of complication and lower survival compared to patients transplanted for stable DCLD patients. So liver transplantation is contraindicated when survival after transplantation is lower than survival without transplantation, and LT should be performed only when the predicted survival of liver transplant, predicted survival after transplant looks more than 50% at 5 years. So patients undergoing LT for ACLF are having higher risk of post-LT complication and reduced 90-day survival as compared to patients undergoing liver transplant for DCLD. And the survival at 1 year for ACLF transplant is 77% compared to DCLD patient, they have a 96.1%. So contraindication while subjecting patient to a liver transplant are that patient having sepsis, documented sepsis with 2 or more organ failure, worsening renal failure with a serum creatinine of more than 4 milligram deciliter, increase in serum creatinine by 300% from the baseline and need for renal replacement therapy. Pulmonary dysfunction with a PF ratio of less than 150 and HE requiring ventilatory support more than 72 hours. 4 or more organ failure at any time, active gastrointestinal bleeding and hemodynamic instability requiring noradrenaline more than 3 milligram per hour. These are considered as one of the absolute contraindication for before proceeding liver transplant. Liver transplant is a therapy of choice and potentially only treatment available option for ACLF grade 2 and grade 3 patients. However, there are a lot of obstacles while subjecting these patients to liver transplant, and one of them is the mindset of the transplant unit, transplant hospital. The other is poor socio-economic support on the part of the patient, financial constraint, not a suitable
Can
donor.
you summarize?
Early liver transplantation may be considered for very small number of patients who meet specific selection criteria for severe alcoholic hepatitis. And though LT is the only potential treatment option for grade 2 and grade 3 SALF, it should be used very judiciously.
Thank you. Thank you. Dr. Kapil, I will request you to come on stage, please.
So before we go on to the questions, just a question to the house, like how many agree to transplanting acute alcoholic hepatitis from the audience? Just a show of hands. How many agree that they should be transplanted early? And for medical management. So how many say that they should be given a priority towards medical management? So 90% are diplomatic neither way.
Actually, one of the most common indication which has been for liver transplant in India and probably all over the world is alcoholic cirrhosis. And initially it was hepatitis C cirrhosis, but now it is being replaced by NASH cirrhosis, and which is also associated with wrong food habits and wrong lifestyle. Though we cannot compare alcohol with NASH, but it is a same thinking which is happening. And even patients with intravenous drug abuse, when they develop hep B, hep C cirrhosis, they are also, not excluded from this liver
So basically, Vaibhav wants to say that 6 months abstinence should not be considered as a criteria before enlisting patients, right?
If we follow that rule, then we will probably miss out a lot of patients who may be benefited by liver transplant.
Right. We have both benign debaters. So, though Sir showed 3 cases and he managed all 3 cases medically, 2 improved, survived, and 1 died. So my question to both of you is, at the outset, the first presentation of ACLF, acute on chronic liver failure, jaundice followed by ascites because of severe alcoholic hepatitis. If a patient, if suitable, no organ failure is there right now, MELD is more than 30, and patient's relatives are ready for proceeding for transplants. So my question is to both of you, would you at the outset consider for transplant, or will you say no to transplant, first medical management, if they non-respond, they shows non-responder, or they have developing organ failure, then only to proceed for transplant?
So if patient comes, as you said, all ideal conditions, so maybe patient has chances that he may survive on its own without giving any supportive therapy like Plex or anything. We'll wait for 1 week. At 1 week, we'll decide. Suppose patient doesn't improve, bilirubin is not improving, patient is not responding to medical management, I will suggest to go for transplant. I will not wait for him to, if the option is not available, there are other problems like financial non-availability of donor, other problems, other things are there, then I will consider other things like supportive therapy, Plex, steroids or other thing. But if patient is present, all ideal conditions are present, not improving to medical therapy, out front, I think.
Kapil sir will proceed for, they will say no to the relatives that wait for the medical managements to have its action.
So what to do?
To see the response.
So otherwise patient will...
We will keep donor ready and we will keep on monitoring the patient. We won't subject patient at the outset, right from the beginning. But if patient is in ACLF grade 3, we will proceed for transplant provided the sepsis is excluded and extrahepatic organ failure is not that much deteriorated. We will proceed for transplant. In ACLF grade 2, we will remain skeptical. If it is improving, we keep patient on medical management.
So if you see the cliffs of a recent publication in 2021, so they have shown the outcome in cliff 1, cliff 2, cliff 3, ACLF 1, 2, 3. ACLF 1 has a better outcome as compared to ACLF 2 and 3, even the liver transplant. So if the survival of ACLF 3 is only 75%, So why should we wait and decrease the survival from 85 to 75%?
I was talking for like apasal ACLF, where there is a very high chances of survival in ACLF grade 1 with medical management. But if we apply the definition by Cliff so far, yes, from ACLF 1 only, patient should be considered for liver transplant.
So,
because they include the decompensated cirrhotic patients. When we talk of Cliff so far, they include decompensated cirrhotic patients with ACLF. So I don't think there is any scope for any medical management when we talk of Cliff so far or EASL ACLF.
Okay. APASL also has now clarified this ARC score. So if ARC score is less than 10, so they also don't advise transplant at the outset. But if ARC score is more than 10 at the admission, if no other option, direct transplant.
And my question to Dr. Kapil is, it is just the number of organ failures that is important, or which systems are affected that is also important? Say for example, if you have somebody who has renal issues and needs inotropes, and there is another patient who needs inotropes and has respiratory issue also, which one you would prefer?
So the score doesn't differentiate. So it's then case to case basis. Otherwise, if we take the scores, they don't differentiate which organ you are taking. But if KKI is mild and on testing we find it's only HRS, so that can be taken. I think he has also shown that up to 4 can be taken. But I think 2.5, all data shows its survival is better.
Yeah. So just to conclude, what we have realized is from the debate is anybody with alcohol related ACLF, if there are no organ failures or there is reversibility of organ failures, you wait for medical management for his reversibility. You don't wait for too long for medical management and rightly, timely decide on a transplant and get the transplant ready. But by day 7, you should have made your decision. This is what we understood.
Yeah, the data is presently not more than 10 days. And patient, as soon as we find the patient, he should be sent to a transplant center. If he is lucky, he should improve. If he is not lucky, he should be sent for the transplant.
Thank you. We conclude this.
Thank you, sir, and heartfelt thank you to all the chairpersons. Next topic is albumin infusion in cirrhosis, why and why. For that, I would like to invite Dr. Ketan Joshi, sir, Dr. Anil Kulsreshta, sir, Dr. Radhika Chavan, ma'am, and Dr. Kamlesh Fatania, sir, as a chairperson. And the speaker will be invited by the honorable chairperson.
At the outset, let me thank Noble Group of Hospital for making this conference and making it big. They are doing it for last 4 years, and this time I think it is one of the most well-attended conference in the city of Ahmedabad. And we always believe that if you have academic credentials and academic topic or good academics, then people will definitely come. And I would like to thank all the attendees that they have reposed their faith in us. And now to the next topic, I will invite Dr. Saurabh. Saurabh, the man with Midas Touch from Midas Institute, Nagpur, and he will be talking about albumin infusion in cirrhosis, why and when. As we practice cirrhosis, I think all physicians, they will agree that albumin is to be used. We cannot run away from albumin. Now I think he is going to give us guidelines whether it should be used in a restrictive way or a liberal way. Thank you, sir. Please, over to you.
Okay, hi, good afternoon, everyone. It's a pleasure to be in Ahmedabad. It's a beautiful city, and thanks, Yogesh, for having me for the second time this year. So what a fantastic attendance. And today we'll be switching gears from liver transplant and cirrhosis to albumin infusion. when and why. So what I'll be doing is, I understand a lot of you are physicians, so we'll try to keep it simple to understand why do we use albumin in these patients and where do we exactly should be using it. So if you look at the pathophysiology of compensated and decompensated cirrhosis, what really happens is there's increased intrahepatic vascular resistance that leads to portal hypertension, leading to splanchnic arterial vasodilation, and there's reduced effective arterial blood volume, which ultimately leads to increased cardiac output and restoration of the effective arterial blood volume in a compensated stage. But these things get further worsened in a decompensated stage where there is severe splanchnic arterial vasodilation, and therefore there's significant reduction in the arterial blood volume, leading to increased cardiac output, activation of the sodium retaining and their vasoconstrictor systems, ultimately leading to ascites, and further worsening leading to hepatorenal syndrome with intense vasoconstriction in the renal vasculature. So if you look at albumin as a molecule, we've learned all along during our medical college days that it has great properties for plasma volume expansion, and that is where its real role stems from in our routine management. So if there are earlier reports describing use of albumin cirrhosis back in the World War II era, so now the current indications for use of albumin in decompensated cirrhosis by and large are the following three. And we'll talk about this and then we'll talk about some newer indications. Paracentesis-induced circulatory dysfunction. So essentially what happens is post-paracentesis, the patients can develop circulatory dysfunction, especially if a large volume paracentesis is done, leading to activation of the plasma renin-angiotensin system, ultimately reduced blood pressure, renal dysfunction, hyponatremia, encephalopathy, and reduced survival. So use of albumin has been effective in this setting. This is the earliest randomized controlled trial from 1988, where they combined albumin with large volume paracentesis. And what you can see is there was no difference in complications overall, but there was difference in hyponatremia and renal failure rates. And what they found was patients who developed hyponatremia and renal failure were the ones who had lower mortality. Now fast forward to 2012 and meta-analysis, 17 trials, almost 1,200 patients. Incidence of post-paracentesis circulatory dysfunction, much lower when you use albumin, and mortality is much lower. Next, spontaneous bacterial peritonitis, which is basically ascitic neutrophil count, more than 250 cells in the absence of any intra-abdominal source of infection. It leads to increased circulatory dysfunction, just like I showed you in the earlier slides with post-paracentesis, increased circulatory dysfunction leading to increased renal failure and ultimately increased mortality. So again, randomized controlled trial published 1999, landmark study in New England Journal of Medicine, where they combined antibiotics for SBP with or without albumin. And what you can see distinctly is the rate of renal failure went down when you added albumin to antibiotics, and the rate of mortality reduced significantly when you added albumin to antibiotics. Fast forward 2013, many more studies ultimately reduced renal failure and reduced mortality in this setting. Moving forward, we'll briefly touch upon hepatorenal syndrome. Dr. Sareen very nicely outlined hepatorenal syndrome. I'll not go into the depth of this, but basically it's a fairly complicated definition, but for most physicians out there to understand, absence of any obvious renal failure etiology in a decompensated cirrhosis, it's a diagnosis of exclusion. So if there's no use of NSAIDs, no contrast, no prerenal etiology, these are the hepatorenal syndrome patients. And what pathophysiologically I showed you earlier is there's intense splanchnic vasodilation, ultimately leading to intense vasoconstriction in the arterial structures in the kidneys, which ultimately leads to renal failure. Very beautifully demonstrated in these studies earlier on, where they used albumin with terlipressin. We learned it in the talk earlier today, use of vasoconstrictors, and I'll show you how albumin use in combination with vasoconstrictors. You can see at baseline and following treatment, how the sodium improves, the creatinine reduces, and the plasma, the mean arterial pressure increases, and so on and so forth. So this is what, with all of this data, the guidelines, the EASL as well as the ASLD guidelines have recommended use of albumin in various settings, and I'll just summarize it for you. So if you see for post-paracentesis circulatory dysfunction, we are looking at 6 to 8 grams of albumin per liter removed. So for you all who are physicians, 8 grams per liter of albumin removed, per liter of fluid removed, especially more than 5 liters, but in an Indian context, I think maybe 3 liters probably is adequate, purely because patients can develop paracentesis-induced circulatory dysfunction at lower paracentesis volumes in India. For SBP, the ASLD guidelines has a specific feature with renal failure and bilirubin high, but for EASL, they say all SBP patients, these are the doses. For HRS, by and large, a gram per kg for day 1 or 2, followed by about 40 grams a day after. All right, so moving forward and how things have changed with albumin. Decompensated physiology, cirrhosis physiology, now current understanding has evolved. What we have learned is in portal patients with portal hypertension, they have translocation of bacteria. With liver injury, there is damaged cells, both of this leading to release of molecular patterns, activation of the innate immune system, release of pro-inflammatory molecules. All of this is the root cause of splanchnic vasodilation. Splanchnic vasodilation leads to dysfunction in various organs and ultimately mortality. So beyond the oncotic properties, now we have learned that albumin also has non-oncotic properties, binding, scavenging, immunomodulation, anti-inflammatory activity, etc. So let's see how albumin acts in the pathophysiology of decompensated cirrhosis. The binding capacity is essential to bind these molecular patterns that are released in portal hypertension. Modulating the immune system reduces the inflammation. Antioxidant properties reduces the pro-inflammatory molecules. Plasma volume expansion, as we discussed earlier, will counter the vasodilation and ultimately protective function of the organs with endothelial stabilization. So therefore, albumin goes beyond just your routine property of plasma volume expansion. And also what we have learned is that there is a concept of irreversibly oxidized albumin. So as patients have decompensated cirrhosis, their quality of albumin gets worse, and this is associated with poor survival. So just putting it together in decomp cirrhosis patients, there's a state of elevated inflammation, low albumin levels, and all these albumins are also have poor quality. Now therefore, moving forward, looking at albumin in these patients, some authors decided to assess and see what happens to the inflammation. And what they found was there's reduction in inflammatory markers when albumin was used in decomp cirrhosis patients because of the properties I showed you earlier. This led authors to perform studies to understand if using albumin led to better outcomes. This is first study randomized controlled trial where they used diuretics for ascites with 12.5 grams a day of albumin in the hospital, followed by 25 grams a week. Now this is beyond your standard indications. So you see there's reduced ascites recurrence, reduced hospital readmissions, but they did not see a survival benefit. And this led the authors further later to do a huge study which was published in Lancet, the ANSWER trial, which is use of human albumin for treatment of ascites. And I'll keep it brief. 431 patients were randomized to standard treatment with or without albumin and followed up for 18 months or until they underwent transplant or TIPS. No difference in baseline features between the two groups. The serum albumin concentration expectedly was more in those who received albumin. Importantly, overall survival improved with use of albumin. And use of albumin was an independent predictor for mortality. Bottom line suggesting that albumin use in the long term reduced mortality, reduced paracentesis requirement, reduced rates of refractory ascites. overall reduced complications. You see various complications, SBP, non-SBP infections, encephalopathy, renal failure, HRS, hyponatremia, everything improved. The GI bleeding was not different. And adverse events, there was no difference in adverse events between the two arms. Quality of life was better when you used albumin because of reduced hospitalizations. And hospitalizations reduced, as I showed earlier. Now the problem is the cost effectiveness, and they analyzed this in Europe, and what they found was, I'll keep it simple, 21,000 euros were required to improve the quality of life for patients to live for for 1 extra year. So that's in the European context. So if you look at overall ANSWER trial, with long-term albumin, there was increased survival, lower complications, reduced paracentesis, reduced refractory ascites, reduced hospitalizations, improved quality of life, but the main problem is it came at a significant cost. Further trials, and I'll skip through some of these. This is a trial of using midodin with albumin until transplant, and problem with this study was half the patient got transplant in 4 weeks, so didn't see any benefit. And for refractory ascites, another trial showing improved survival, reduced hospitalization. And ultimately, to put it together, initial studies showed reduced complications, no improvement in survival, but further studies showed reduced complication, improvement in survival. And this was consistently sort of seen over time, except for that one study which was inadequately powered. So overall, a trend towards reduced complication and improved survival. And then most recently was a study which had a different flavor. They used albumin for any patient in the hospital. Now this was not that other study where they used it for long term when they were discharged from the hospital. This is ATTIRE trial, New England Journal of Medicine study. Basically, any patient with low albumin coming into the hospital was considered for the trial, and they were given albumin or not. So these are patients, and you see most of the patients were ineligible because they either did not have low albumin or the predicted stay was less than 5 days. So most of the patients who were actually enrolled did follow through. No difference, there were no difference in the baseline characteristics. Most of these patients were admitted largely either for infection or ascites. And you see a lot of patients in the albumin group, of course, got more albumin. Importantly, composite primary endpoint was not achieved, and there was no difference in complications or mortality between the two arms. There was a trend towards reduced renal failure when you used albumin, as expected, because it improves the circulatory dysfunction. So I'll just put it together real quick. My take on various studies and data. Overall, with long-term albumin, there's a trend towards reduced complications and reduced mortality. The dose of albumin, which to improve survival, we are looking at 40 grams a week. Long-term follow-up needed to see benefit in these patients. Cost of therapy in India, and most of you would be worried about that, we are looking at about 4 lakhs per year, considering 4,000 rupees of albumin dose. Short-term albumin in hospitalized patients has no benefit. So let's understand when do you actually have to use albumin properly. And last slide here, summary to put it together. Standard indications include large volume paracentesis, SBP, and hepatorenal syndrome. And I showed you the doses earlier. New indications are disease-modifying effect of albumin, which was the ANSWER trial, looking at 40 grams about once a week for a long-term administration with some improvement in mortality. So I'll end it there, and I'm happy to take any questions. Thank you.
Hi Saurav, very nice talk and very nice slides.
Thank you.
So
Thank you.
I have a question. What if patient develop reaction to albumin?
Yeah.
So majority of the time we see patient developing reaction, not tolerating albumin. So in that case, what exactly we have to do?
Yeah, no, good question. I think can be a practical challenge. I suppose we could start if it's a mild reaction with some skin rash or so. You could consider using antihistaminic medicines to prevent this and attempt and see. Of course, a major reaction will preclude us from using albumin as a therapy. Not many other options, unfortunately. Albumin is the only thing that you can try, and there's really no other alternative. If it's not there, then we have to live with it, and he cannot get it. So,
Any further questions? No? Okay. Yes, sir.
Right, and I think what I showed you was like largely a basic data for standard patients. Now we have to use our clinical mindset and ensure and determine that we are not using incorrectly and excessively in patients, say with an ejection fraction of 20%. You have to be cognizant of how much volume are you giving. So those are clinical decisions that to be individualized based on each patient, but this is a more gestalt of what we are looking at overall for treatment. Okay.
Thank you, sir.
Thank you so much.
We will conclude the session.
Thank you, chairpersons.
Thank you, sir. Next topic is management of anticoagulation in cirrhotic patients. I would like to invite Dr. Geria, HOD of Medicine, Surendra Nagar, Dr. Pratik Parikh sir and Dr. Parth Shah sir. The speaker will be invited by the Honorable Chairperson.
Bad.
The next topic is management of anticoagulation and antiplatelets in cirrhosis. For that, we have Dr. Gaurav Chawla from Kanpur Medical Center. Dr. Gaurav Chawla will enlighten us in a very confusing topic, which we often overcome during our clinical practice, and what to do, what not to do. Over to you, sir.
At the outset, I would like to thank Yogesh for giving me this topic and speaking in front of you. So basically, I'll be talking about how is the coagulation in liver diseases, how we evaluate coagulative abnormalities, what is the incidence of thrombosis in cirrhotics, what is the status of anticoagulation in cirrhotics, as well as whether to give anticoagulation as an antifibrotic agent, and then what are the drugs we give. So liver is required for production of majority of factors involved in coagulative process, and liver's the synthesis of both procoagulants and anticoagulant proteins are decreased. So we are in a phase of rebalanced homeostasis when we consider a CLD patient. So in normal equilibrium, we have abundant amount of these proteins, and whenever coagulation is required, only less than 50% of the proteins are required. But if we see the primary hemostatic drivers, thrombocytopenia is there, abnormal platelet function is there, decreased production of thrombopoietin is there. On the other hand, pro-hemostatic driver, we have elevated levels of bone build factor because that is synthesized by endothelium also. There is low levels of ADEM TS13. If we look at the coagulation parameter as such, there is low level of factor, vitamin K dependent factors 2, 5, 7, 9, 10, 11. There is dysfibrinogemia. And if we consider in cirrhotics, there is elevated levels of factor 8, low levels of protein C, protein S, antithrombin, hepatic cofactor 2, and there is inherited thrombophilia. Among the fibrinolysis markers, there is low levels of alpha-2 plasmin protein, factor 13, TFI, and elevated levels of tissue plasminogen activator. And there is low level of plasminogen on the other hand. But if you see, the amount of protein is very less and coagulation is very unstable in cirrhotic patient. So this diagrams highlight the amount of protein imbalance. As the severity of cirrhotic increases, the more the imbalance, the more the system is in strain, because as the severity increases, there is more systemic inflammation happening, there is more gut translocation happening, which causes infection, which causes renal failure, and entire system is unstable. So how we evaluate coagulative abnormalities? Usually, traditionally, before doing procedures, we do PT with INR, and if INR is less than 1.5, we are okay, but that is a crude manner. Usually, fibrinogen levels seems better predictors for bleeding in patients with high INR. And usually for varicose bleed, as Dr. Nile has told earlier, that FFP transfusion is not required in all patients. Only if fibrogen levels are low, you can consider giving cryos. And usually for invasive procedures in cirrhotics, platelet counts more than 50,000 are considered adequate. But there is no sound data on this threshold also. Low platelet just indicates this large spleen size, and it is influenced by the degree of portal hypertension. Some data is there which has shown that low platelet count, even if patient is given anticoagulants on a compensated cirrhotic patient, can be safely given. So recently, for managing the coagulation, there is thromboelastography and thromboelastometry. What they do is they explore the clot formation in a non-centrifuge blood and final clot stent in the whole blood, as well as presence of fibrinolysis and premature clot descent. So it's give a graphical picture of the clot. Their blood is incubated at 37 degrees and suspended in a heated cup, and it is connected to a detector system with torsion wire in TEG or with optical detector in ROTEM. But this also doesn't take into account the platelet dysfunction and the effects of von Willebrand factors on coagulation. So if we consider this is the graph which we get, basically R time is the clotting time which represents the initial fibrin formation, R time in TEG or clotting time in ROTEM. Then we have a K time. K time is the clot formation time which measures the rate of clot formation and reflects the building up of fibrin and cross-linking of fibrin. Then we have a maximum clot's firmness or maximum amplitude, which represents the ultimate strength of the clot, which is the fibrin and platelet. And then LY13 or CL13, it measures the rate of amplitude reduction from maximum amplitude at 30 minutes, and it detects fibrinolysis. So most liver centers are using this for giving product transport. This is the graph representing a prolonged clotting time in a patient given with heparin. So here you can see it's a short clotting time with hypercoagulable state. Now thrombotic in cirrhotics. In cirrhotic, if you see INR is mostly elevated, and most of us think that they are auto-anticoagulated and usually there won't be incidence of thrombosis, but long-term observational studies have been done assessing the thrombosis and the higher risk of ischemic stroke and venous thrombolism compared to patients without the liver disease. And some surveys have told up to the tune of 1.7 to 2-fold they are more prone. And among the cirrhotics, NAFLD cirrhosis and HCV-CLD cirrhotics are more prone for venous thrombolism. And in all these cases, the presence of cirrhosis in patients with thrombolism has been associated with increased mortality. Now coming to splanchnic venous thrombosis, the prevalence and incidence of extrahepatic portal venous thrombosis vary mostly according to the severity of the associated liver disease. So if you see incidence is about 5% in one, 11% in 1 and 5 years if it's a child A. But if it's a child C, prevalence was up to 15 to 23% and incidence between 7 to 16.6% in the first year. And this portal venous thrombosis in 75%, it's not like fully, it may be transient, occupying a portion of the portal vein, and it may be transient. If you do ultrasound 3 months or 6 months later, you may not see portal. So it may be transient phenomena also. And more common cause of portal vein, most common is seen in NASH cirrhosis. Now, what are the potential indications of anticoagulation in cirrhotics? So if we see the Babino 7 guidelines, it is clear that portal venous thrombosis occupying more than 50% of the lumen irrespective of SMV involvement. If portal venous thrombosis occupies less than 50% and there is associated SMV thrombosis, then you should give. If any patient of portal venous thrombosis awaiting liver transplantation, you should give anticoagulation. Any acute portal venous thrombosis, you should give low molecular weight heparin, warfarin, or a combination, which we will discuss in future slides. And then how long? Usually there should be resolution of the thrombus or at least 6 months, or if a patient is awaiting liver transplant, till liver transplantation has been done, we should give anticoagulation. So some data is there. This was a study in which 55 patients were cirrhosis and acute portal vein thrombosis. 60% of patients were treated with low molecular weight or warfarin, and canalization was 6.8 months, 60% canalized. Platelet count less than 50,000 and use of warfarin was associated with increases of bleeding in this study. Then again, this was a study done on 28 patients, and complete canalization of portal vein occurred in 33% and partial recanalization in 50%. Overall, complete resolution was seen in 75% of the patients. There was no significant side effects, particularly bleeding complications, were observed during this study. Now, this was a study, landmark study, 35 patients in which LMWH was given, naldoparin for 6 months, and there was 36% complete and 27 partial. So whatever I want to say is that the study was done on a skimpy number of patients, so we don't have a robust data as of now. This is the meta-analysis, largest meta-analysis published in 2017 Gastro with 353 subjects. Portal vein canalization was seen in 71% of the patients, and there was no risk or difference in major or minor bleeding between the groups. And surprisingly, the spontaneous varicose bleeding, which we are afraid of, occurred in significantly lower proportion of patients who received anticoagulation versus those who did not receive. So now new drugs have come which are direct acting oral anticoagulations for the treatment of portal venous thrombosis. So usually we have case reports and small retrospective studies which have shown these direct acting oral anticoagulants are safe in patients with mild to moderate cirrhosis. So this is a randomized controlled trial, a beautiful trial. 80 subjects were randomized into rivaroxaban versus warfarin for management of acute non-neoplastic portal vein thrombosis. And resolution of portal vein thrombosis was seen in 85% of the patients compared to 45% of patients who received warfarin. There was a survival benefit, 24.4 months versus 10 months, rivaroxaban versus warfarin. And then there is complications. None of the complications happened with rivaroxaban, which happened with warfarin, which include upper GI tract bleeding, hepatic decompensation, progression to mesenteric ischemia, recurrence, or death. So now if there is no thrombosis, any role for anticoagulation for portal venous thrombosis? So because portal venous thrombosis is an indicator of progressive liver disease, it indicates that there is decompensation happening at the time of portal venous thrombosis. So there is one study, enoxaparin, which prevents portal venous thrombosis and liver decompensation in advanced age. 70 patients were given LMWH for 48 weeks. So they found that 12 months of enoxaparin was safe and effective in preventing portal venous thrombosis, and they used child score of 7 to 10. They were recruited in this study. And they also showed that it appeared to delay the occurrence of hepatic decompensation and also to ensure improved survival in this study. So anticoagulation may have, if there is a documented portal venous thrombosis, definitely it has a therapeutic role of portal venous recanalization, which decreases the bacterial translocation and improves survival. But in future, anticoagulation may have a role in prophylactic also. When we have more data, it may decrease bacterial translocation, it decreases the formation of portal venous thrombosis, it decreases the decompensation, and it will improve survival. So some data on whether anticoagulation can be used as antifibrotic therapy, because the alteration in hepatic microcirculation and intravascular thrombosis in sinusoids and intrahepatic veins causes a phenomenon of parenchymal extinction, which causes irreversible loss of continuous hepatocyte, and this gets replaced by fibrate tissue. Some studies, animal studies, have shown benefit with reduction in hepatic fibrosis, with decreased hepatic stellate cell activation. Some clinical studies are also there, but again, data is not that. One of the study which I want to show is the WAFT-C study, which is a beautiful study. Actually, they tried to give warfarin for 2 weeks in a post-Hep C transplanted patients when DAs were not available. So at 1 year, they found that significant reduction in the proportion of patients with increase in fibrosis score, 23% versus none of them who were given warfarin. But they terminated the trial at 1 year because that time DAs became available, so they were given subsequently DAs. No patients were withdrawn due to severe adverse effects directly or secondary to anticoagulation in this study. Now, which anticoagulant to give in a cirrhotic patients? Usually, most of the data has been with LMWH, parenteral anticoagulation. though cirrhotic patient has decreased antithrombin levels, but which may think that LMWH may not act, but several in vitro studies have shown as increased effect of LMWH in cirrhotic patients despite low antithrombin levels, despite low anti-10A levels. And usually we use heparin only when patient is having renal impairment. If creatinine clearance is less than 30, then LMWH should not be used. Then unfractured heparin we use and we monitor APTD then, and it should be 1.5 to 2.5. So till data, LMWH is the anticoagulant of choice in cirrhotic patient. So this is how the different anticoagulations works. So warfarin works on factors 2, 7, 9, 10. Heparin and factor usually acts at factor 10 level as well as factor 2A levels. We have now oral anticoagulants which I was talking about. Factor 10 levels which inhibit are rivaroxaban, apixaban and edoxaban. Factor 2A inhibitors is dabigatran, which are commonly used by cardiologists these days. So oral anticoagulants, just warfarin has traditionally been used for venous thromboembolism for prevention of stroke as well AF, but all the studies have excluded liver disease patients done by cardiologists, done everywhere. So recommended INR is 2 to 3, but this warfarin treatment is particularly challenging because of significant plasma protein binding is there, 99%. And it is predominantly eliminated by liver through cytochrome P450 dependent metabolism. And baseline INR is often elevated in CLD patients. Just the dose of warfarin and target INR are not well defined. We think that we are giving adequate anticoagulation, we may be giving undercoagulation, and we may be giving when we exceed INR, we may be suprahemolytic giving them. So compliance and adherence is problem with warfarin, that's why data is not good. So this study is a population-based study, only study in which they have included liver disease patients. Antithrombotic therapy was given, and overall rates, they found that it was non-adherent, non-persons were highest in the warfarin. And primary non-adherence rates were highest in patients with liver disease than those without the liver disease. So as we have discussed the direct acting oral anticoagulant, several randomized trials have showed these benefits, and our cardiologists have shifted from warfarin to these agents, apixaban, rivaroxaban, dabigatran, because no monitoring is required and they are quite safe, but all the trials again have excluded liver disease patients. So just before prescribing this, we should take into account the renal parameters, drug-drug interactions, weight, the previous bleeding episodes or thrombocytopenia. So just finishing with pharmacokinetics of these oral anticoagulation agents, if you see all of them have hepatic clearance like warfarin, we have already discussed. Apixaban is 75% hepatic clearance, 25% renal clearance, but no monitoring is required, and we have a reversal agent also with it, andexanet alpha. Dabigatran, short half-life of 12 to 17 years, again 80% renal clearance, 20% hepatic clearance. It doesn't require cytokine 450 monitoring also, no coagulation monitoring, and we have a reversal agent for that also, idarosumab. And similar with edoxaban and rivaroxaban. So these are the pharmacology of different agents. So currently, if we have to prescribe these drugs, usually child A has been considered safe. All novel oral anticoagulant agents can be given in child A. Child B we should use with caution, and warfarin to be considered. Child C we should not use. We should use only either lenalidomide or warfarin. Coming to the antiplatelet in cirrhotics, so this was again a population-based studies. They found that in cirrhotic patients with acute MI, dual antiplatelet offer benefit with decreased recurrence of MI but increased GI bleeding, and the highest bleeding risk among cirrhotic patient.
So we can sum it up because time.
Yeah, this is my penultimate slide.
Sure, thank you.
And the highest bleeding risk in cirrhotic is in a subgroup of severe thrombocytopenia and elevated portal pressure. So whenever we give these drugs, we can tackle varices before giving. And we should give PPI therapy, we should give beta blockers for decreasing the bleeding risk. And use of aspirin alone does not appear to increase the risk of GI bleeding. And the increased risk of GI bleeding for patients on aspirin and clopidogrel does not translate to increased mortality. So to summarize, in the past, patients with liver cirrhosis were thought to be increased risk of bleeding. So compensated cirrhosis patients have a normal cognitive balance, which get altered when liver function gets worsened, when there is infection, when there is bleeding, when there is AKI and system becomes unstable. And when this happens, they are more prone for thrombotic rather than bleeding. And anticoagulation plays a favorable role when used prophylactically or therapeutically, but we need larger trials, we need more robust data. And successful anticoagulation is associated with improved survival and lower rate of decompensation. Treatment till date most of the studies are done with LMWH and vitamin K antagonist, but preliminary data has shown that novel oral non-vitamin K anticoagulants can be used safely in patients with liver cirrhosis. And dual antiplatelet offers benefit with decreased risk of thrombosis MI, but there might be increased risk of GI bleeding, but which can be tackled by endoscopist, and there is no increase in mortality when given antiplatelets and GI bleeding. Thank you.
Excellent elaboration. If any question, come to the.
Nice talk, Gaurav. My question is, acute patient established cirrhosis decompensated, present with abdominal pain. You do an ultrasound, it shows acute thrombus, or maybe thrombus, you will never be able to say acute or chronic. So what do you do if you have grade 4 varices?
Sir, grade 4 varices, I will band that immediately, and then I will start LMWH after banding them.
Same day? After how many days? Because banding will produce ulcers. You will require a second session of banding that will produce more ulcers.
Yes, sir, but
so how long do you wait?
No, sir, I will start on the same day itself because if we cannot wait, ulcers may not happen to every person. We will give PPI therapy also. Ulcers may form after 2 weeks, 4 weeks. But as you told, patient is having acute thrombosis, probably an acute worsening, acute presentation is there. So I will not wait. If that happens, we can tackle that time. We can stop after 4 weeks for a particular 1 day and give support, whatever required, and then tackle the bleed, sir. But that is not, we will give immediately on the same day.
Sir, if I may ask a question, sir. So Gaurav, thank you for the nice overview. Now I understand this is a scary scenario for all us hepatologists practicing. If a patient has varices, high risk of bleeding, and then giving anticoagulation, it's a hard challenge. Now, any thoughts and any data on use of IR techniques to recanalize the portal vein in these situations, or certainly in acute thrombosis?
No, sometimes they have also used if anticoagulations cannot be given, or some tips have also been used in some studies but that also patient should be stable and other things. And most of them have used LMWH for recanalization of the portal vein in such scenario.
Can I answer that, Saurabh? Recently, we reviewed the literature on thrombolysis and thrombectomy in patients with portal vein thrombosis. Primarily, it's meant for non-cirrhotic patients. For cirrhotic patients, it is an extremely big challenge for 2 reasons. Because access to the portal vein is either through the transhepatic route, or through the transsplenic route, or through the transvenous route, which is very difficult. As Gaurav said, most of the times, in fact, in acute, it is very difficult to diagnose acute thrombosis. You never know. Even the radiology doesn't help you. Recommendations are in a patient with cirrhosis who is not destined to undergo liver transplantation, there is no harm in waiting, because there is a good 30% chance of spontaneous resolution of the thrombosis. Because as you said, it is a rebalanced state. You have enough of anticoagulants, you have enough of procoagulants. So what do we do in a situation like this is, you anticoagulate the patient, and if you are going for thrombectomy, you have to follow it up with tips in cirrhosis, which is a huge challenge, because there is a risk of, if you are doing thrombolysis, there is increased risk of bleeding. Thrombectomy is better than thrombolysis, but primarily in the non-cirrhotic setting. That is the problem.
Sir, non-coronary events, when patient is having already clopidogrel aspirin, and when patient get hematemesis, what should we do?
Sir, we should do scopy and so their mortality has not been increased in such patients. So we can manage whatever the ulcer, if this is because of ulcer, we can manage ulcer bleed. If because of varices, we can do banding. Temporarily, we should stop the antiplatelets, and they have shown that switch over to single antiplatelet if required. So when to take, we have to discuss in conjunction with cardiologist what they want, till how long they want to, how badly, because that is all between 2 departments they have to discuss, but single antiplatelets can be safely given.
Their clopidogrel is better or aspirin is better?
Aspirin is better than clopidogrel, sir.
Thank you.
Just a single last question for me. Some patient is there who has undergone PTCA twice in a year, okay? And he is cirrhotic and he is keeping his platelet below 50,000 because of cirrhosis. How we should treat with double depth? Can you guide us?
Yes, sir. We see dual antiplatelets have shown, as I told, data is there that they are beneficial. They will reduce the incidence of, again, recurrent of MI and recurrent thrombotic complications. So there was a large Taiwanese study which I showed. So, but this will occur at the expense of increased episodes of GI bleed. So, but GI bleed episodes, in such situations, if your endoscopist is good, he can manage therapeutically whatever is the cause. But before giving, two tips are there. You can give PPI therapy, you should be given, you should tackle the viruses and then give dual antiplatelets. And if he is bleeding, then tackle the bleed and then you have to buy the time and then you have to discuss. So it's a balance in conjunction with cardiologist, and you have to take case by case, you should handle that.
What I am saying is platelet is persistently low. It is below 50,000 because of the cirrhosis. In that situation, what we'll have to do? While giving dual platelet.
Sir, we'll have to close the session. Sir, we will have to close the session. We are running late. You can have a discussion over tea. Sir.
Platelet should only be given when they are less than 20,000 and bleeding. Otherwise, we should not give. It's because of hyperspin.
Thank you and good round of applause for sir.
Thank you, sir, and thank you, chairpersons. Next topic is management of HCV in 2022. For that, I would like to invite Dr. Umang Rathi, sir, Dr. Apurva Shah, sir, Dr. Ashwin Gadvi, sir, and Dr. Surendra Gupta, sir, as the chairperson. The speaker will be invited by the honorable chairperson.
The next lecture is on management of HCV in 2022. I would like to invite Dr. Kaushal Madan. Dr. Kaushal Madan needs no introduction. He is a renowned hepatologist.
Thank you, chairpersons. Good evening. And thanks to Dr. Yogesh for inviting me for this particular meeting to this wonderful city of Ahmedabad. So HCV management in 2022, unfortunately or fortunately, I think it has already reached its pinnacle. Over last 2-3 years, there's been no new, advances in the management, specifically in India. So there are new drugs which are coming in every day, but the drugs which are available in India are able to treat more than 95% of the patients. So this is my first message. So we all know hepatitis C has a huge burden all over the world. In India, the prevalence rate is about 0.8 to 1.5% depending on the various studies, and a burden of about 20 to 8 million people, many of which are concentrated in pockets. So this is the natural history. Once a patient develops hepatitis C, almost 85% will develop chronic hepatitis C, 15% will be able to clear it on their own. Of this, 25% over 30 years will develop cirrhosis, and from them, 3% per year will develop decompensation and 3% per year will develop liver cancer. And once decompensated, the yellow line, their survival is quite poor as compared to those who remain compensated. But there is a silver lining. As compared to hepatitis B virus and HIV virus, this virus is easy to cure because its genome stays in the cytoplasm, whereas in hepatitis B, it goes to the nucleus, gets incorporated in the host genome, and very difficult to eradicate. Same is the problem with HIV. So unlike these two viruses, it is very easy to cure hepatitis C, especially over last 5 years, and I'll show you why. And this cure, which is called, which is equivalent to SVR, that's what we call the cure, sustained virological response. So you give treatment, stop treatment for 12 weeks, and if your virus is still negative, it is called sustained virological response, which is equivalent to cure. So earlier, maybe before 2015, this is how we were treating these patients. The cure was painful, expensive. Only 45% patients used to respond, and there were many dropouts. 20% patients would stop treatment because of these injections which they had to take every week. Then came the understanding of the genome of hepatitis C, and just concentrate on 3 regions, the NS3, NS5A, and NS5B. These have revolutionized the treatment of hepatitis C. First came the protease inhibitors. Unfortunately, although they were new drugs, it made the cure even more painful, more expensive, and again there were many dropouts. These drugs were also not available in India. These were grazoprevir and mainly grazoprevir, tilaprevir and grazoprevir. Then the discovery of this particular molecule called sofosbuvir, which is NS5B inhibitor. This made the cure rates go up to 91% in combination with pegylated interferon. And then finally, a combination of NS5A and NS5B inhibitors, which made the cure rates go up to 100%, and the cure became oral tablets, painless. Only 8 to 12 weeks of therapy led to 99 to 100% cure rates. So don't get confused with this nomenclature. Just remember 3 things. NS5B are called buvirs, NS5A are called asvirs, and NS3 protease inhibitors are called previrs, just for the nomenclatures so that you don't get confused. So these are the available drug combinations: sofosbuvir, ledipasvir, sofosbuvir, daclatasvir, sofosbuvir, velpatasvir. The combinations written below are not available in our country, so I will not confuse you further with them and not load your mind with them. So just remember these 3 combinations which are available to us. Sofosbuvir, ledipasvir, which is co-formulated, single tablet. Sofosbuvir, daclatasvir, separate as well as co-formulated, and sofosbuvir, velpatasvir. And I told you it's a combination of NS5B, NS5A. Now the first one is active against genotype 1, 4, 5, 6, and the lower 2 are pan-genotypic. Remember, genotype 3 is the most common genotype in India, followed by genotype 1. In some studies, especially from south, they say that genotype 1 possibly predominates. And in hemodialysis centers, almost 40% patients acquire hepatitis C, and most of them have genotype 1. So just to take you through what kind of patients require what kind of therapy, I'll present 2 or 3 cases. So this is a 31-year-old gentleman who was asymptomatic, presented with deranged LFTs, and further investigations revealed that he was anti-HCV positive, high viral load, genotype 1. I'm sorry, this is the last line you are not able to see, and the fibroscan value of 7. Fibroscan value of 7 means he is a non-cirrhotic. So genotype 1, non-cirrhotic patient, these are the studies. And I told you 3 combinations: ledipasvir, daclatasvir, velpatasvir, upwards of 95% response rate. So genotype 1, non-cirrhotic, all 3 drugs work for 12 weeks therapy. Now if the same patient had cirrhosis, that means his LSM was say 25, then the response rate with daclatasvir is slightly inferior, 93%, ledipasvir, velpatasvir, still good response rate. So just to summarize, if this kind of patient comes without cirrhosis, genotype 1, either of the 3 drug combinations can be given for 12 weeks with 99% response rates. If the same guy has cirrhosis, then do not go for daclatasvir, give either velpatasvir or ledipasvir. I'll make it even simpler once we proceed further. So a second case, a 45-year-old lady presented with chronic fatigue. These were the AST-ALT, AST more than ALT. She was transfused during childbirth, 21 years of age. Very typical history. many ladies come to us in the middle age with hepatitis C virus infection and cirrhosis, and if you take the history, they will tell you that during some obstetric complication, they were given blood transfusion, say 1 or 2 decades back. And further investigation, high viral load, this time genotype 3 and fibroscan showed 22, again suggesting genotype 3 cirrhosis compensated, no ascites, so compensated cirrhosis. So what data we have here? I told you we have to talk about pan-genotypic combination. So velpatasvir, daclatasvir. So these are the studies. SVR12 with daclatasvir, very inferior, only 58%, velpatasvir 93%. So still if you want to use daclatasvir, because daclatasvir is a cheaper drug. So what are the studies? Then either you increase, just concentrate on the middle bars, either you increase the duration to 24 weeks or you add ribavirin and give for 12 weeks. Then you have response rates upwards of 80 to 90%. So same person, if the same person had no cirrhosis, then there is no difference between velpatasvir or daclatasvir. So please be aware about genotype 3 who has cirrhosis. Do not give daclatasvir. If they don't have cirrhosis, then either combination is good. So I've already talked about this. So let me talk about simple national guidelines of our own country given by, prepared by a lot of hepatologists, spearheaded by Dr. Dhiman, who used to be the secretary of INASL at that time. So this is a very simple algorithm. You first detect HCV, patient has HCV or not, and then look for non-invasive markers of cirrhosis, for example, fibroscan. So if the patient does not have cirrhosis on the left side, then soft dacla for 12 weeks, you'll get upwards of 95% response rate. If patient has cirrhosis but compensated, then soft velpatasvir for 12 weeks, upwards of 95 to 99% response rate. So as simple as that. So a third case. So this is a 56-year-old male presented with abdominal distension for 1 month and has ascites. Further, again, hepatitis C virus related cirrhosis which had decompensated. Earlier patients had no cirrhosis, cirrhosis which was compensated. Now this patient had cirrhosis which was decompensated. So what are the options here? So there are 2 options. Either you add ribavirin and give for 12 weeks, or you increase the duration and give for 24 weeks. And which drug? Genotype 3, it has to be velpatasvir. So this was the study which looked at that. And again, you can see that both genotype 1 and genotype 3, it is the combination of soft velpa ribavirin for 12 weeks which gives the best result. So these are the national guidelines which talk about genotype independent treatment for decompensated cirrhosis. So patients who can tolerate ribavirin, all 3 drugs for 12 weeks, patients ribavirin intolerant, then soft plus velpatasvir for 24 weeks. So now let me talk about HCV treatment in special situations. So these are the special situations. One I have already covered is decompensated cirrhosis. Others are post-liver transplantation, end-stage renal disease, HIV, HCV co-infection, relapse after a course of DAAs, and treatment in a resource-constrained country or an area. Of these, it's impossible to discuss all of them, but remember most of them will be covered by SOF plus Velpa for 12 weeks. So if you do not understand anything, just give SOF plus Velpa for 12 weeks. But I'll also talk about end-stage renal disease here in a bit more detail. The problem arose because this particular drug called sofosbuvir as well as its metabolites were not cleared in patients who had CKD4, CKD5 or patients who were on dialysis. They were not able to clear this drug or its metabolite, and that used to accumulate in this concentration. So 171 to 451% extra as compared to those who did not have renal failure. So there was a concern that this might lead to certain side effects. Because of that, there were recommendations that sofosbuvir should be given in a lower dose in these patients. But fortunately, there were many real-life studies based on which this was a meta-analysis of 21 studies of 707 17 HCV infected patients with CKD, and it was suggested that sofosbuvir-based regimens were safe whether given in low dose or normal dose. So CKD or no CKD, you can still give normal doses of sofosbuvir-based regimens. So these are two studies from India. Again, half dose of sofosbuvir, 90% response rate. Full dose of sofosbuvir with velpatasvir, 96% response rate. No side effects of velpatasvir in renal failure. And FDA also has now approved the use of sofosbuvir-based regimens. Important thing to remember is drug-drug interactions specifically, and a very dangerous interaction occurs with amiodarone. So many of the patients who have cardiac issues, some of them may be on cardarone or amiodarone. So remember, sofosbuvir and ledipasvir can cause fatal bradyarrhythmias, so it's an absolute contraindication. So also remember, you might say that a patient received amiodarone for say 15 days and now I am stopping it and now I am giving HCV therapy. Remember, the half-life of amiodarone is 51 days, so you'll have to wait more before you start these patients on HCV. And believe me, nothing is going to happen if you have to wait for 8 to 10 weeks before starting HCV therapy if the patient has chronic hepatitis C. The second important interaction is with PGP inducers and CYP450 inducers. These drugs reduce the concentration of both declatasvir and velpatasvir. I'll just take a minute. And therefore should be avoided the concomitant use, and specifically rifampicin, carbamazepine, phenytoin. So patients who are receiving ATT, let them finish their ATT first and then start them on anti-HCV therapy. Another important interaction is that PPI can reduce the absorption of velpatasvir. So during this 12 weeks, try to avoid giving proton pump inhibitors. If necessary, if the patient has severe GERD, for example, then sofosbuvir velpatasvir has to be taken with food and PPI is to be given 4 hours later. And velpatasvir can increase the exposure to digoxin and tenofovir. In addition, there are several drug interactions with antiretrovirals. This is particularly important for patients who have HIV co-infection. So you can go to this site and look for these drug interactions. Very difficult to remember all of them. So let me summarize now. India has a prevalence rate of HCV of about 0.8 to 1.5%. It causes significant morbidity and liver-related mortality if it is allowed to go unchecked. But if cure can be achieved, it definitely prolongs survival even in advanced stages, even in patients who have decompensated cirrhosis. Now we have moved from painful attempts at treatment to painless cure. Pan-genotypic regimens have further reduced the duration and therefore the cost of therapy. Now there are certain regimens, you can give it for 8 weeks and patient will be cured in more than 99% patients. We don't have those drugs in India, and actually you don't require them also. So just remember these regimens. If you have to go back with one message, this is the message you have to take. No cirrhosis, soft DACLA for 12 weeks. Cirrhosis, soft Velpa for 12 weeks. Just remember these two. Cirrhosis but compensated. Now cirrhosis decompensated, either add Riba if you don't want to increase duration, or if the patient is wary of the side effects of ribavirin, then soft Velpa for 24 weeks. For special groups, remember to refer the patient.
Please finish now. Just
yeah, this is the last
already more than a minute.
Hepatologist. Thank you.
Thank you very much, Dr. Madan, for elaborating very nicely. No questions are allowed because we are already short of time. But I would say now there are very good pan-genotypic therapies available. So I am seeing so many faces, they are practicing at periphery. So they can straightway go for that, even just having hepatitis C positivity. One may go for viral load. Or I think as a senior physician like me, may not go for viral load and straightway may give the therapy. Of course, now my son is available with me as a gastro, so I may go for this referral. Anyhow, thank you very much.
No, HCV-RN is a must because many patients, HCV-RN is a must. You may not want to do a load, you may not want to do a genotype. But you have to demonstrate that patient is having active viremia, otherwise what are you treating?
Yes, sir, yes. So the message should be clear that don't just start, if HCV is positive, don't just
So
start
many
Sofa and
patients
Velpa.
come with us who have anti-HCV positive, but the HCV RNA is negative. So there is no need to treat. This is just an antibody, like what you saw in COVID, just an antibody.
Sir, we are following the same protocol, and as you summarized, only we are now having difficulty. Reba is not available now because these drugs are so effective that procuring Reba is becoming difficult.
I totally agree. Just increase the duration to 24 weeks. We were just having a discussion with Dr. Anil Arora, and he also mentioned this. Cirrhotic patient, genotype 3, 24 weeks. No question asked.
Kaushal, can I make it simpler still?
Yeah, sir.
So why DECLA and Velpa? Why not SWAF and Velpa for everybody? Cost is not difference
Agree.
not much. So it's far easier to remember.
Right.
Just
That's
SOFA and
what I
Velpa.
said. If you have to give just one regimen,
Just
then
remember.
soft Velpa, 12 weeks. Thank you.
Thank you, sir. Thank you, chairpersons. Next topic is management of hepatitis B and C in pregnancy. For that, I would like to invite Dr. Archana Shah, she is a recognized gynecologist of Ahmedabad, Dr. Dinkar Goswami, sir, Dr. Hardik Kotecha, sir, and Dr. Devan Sheth, sir. The speaker will be invited by honorable chairpersons.
I would like to invite for the topic management of hepatitis B and hepatitis C in pregnancy, Dr. Akash Rao, Apollo Multi-Speciality Hospital, Kolkata.
So, very good evening to the August gathering, and thank you again to Yogesh and the entire unit of the Noble Gastro Hospital for this second opportunity of a talk for today. Over the next 10 to 12 minutes, we'll try to take you through to the tale of two viruses, one of which we have a lot of data on, and the second one is sort of pragmatic and more philosophical, more questions than answers. So why do we need to delve into this topic of viral hepatitis in pregnancy? Pregnancy is often the first time that a woman gets access to healthcare. So we should be accessing these moments and opportunities to get the screening as much as possible. Pregnancy is a high impact time, both for the caregiver, for the patient, as well as the healthcare provider. And as we see ahead, there still remains some controversies in management. So we'll delve and dwell on the following aspects. We'll look at the epidemiology. We'll look at it at two aspects: how pregnancy affects the virus and what's the effect of the virus on pregnancy. What is the rates of mother-to-child transmission? How do we screen? And what are the antiviral therapy options? So starting off with the burden of disease that's there. So now from India, we have got two good quality meta-analyses that have shown the prevalence of HBV in pregnancy to be around 0.85. The only factors that have been found to influence the incidence is education, and the risk factors have only been identified in around less than 25% of the cases, which again proves that the transmission is mostly mother to the fetus. And for HCV, the same thing is there. We have got around 14 studies. If you take out one study from Chhattisgarh, your prevalence comes around, pool prevalence of around 1.6. So the first question is, what is the effect of pregnancy on HBV? Pregnancy is a state of immune alterations, and HBV, as we know as a virus, has got its own immune adaptive mechanisms. So there has been data which says that as you have pregnancy, in various states of the pregnancy, you might have alterations and flares in the viruses. This has been shown to be around 45% postpartum to again 25%. But again, if you see the largest study that's there, which was around 1,000 patients, which says that these flares of the hepatitis B virus, which has been checked only by levels of ALT, can occur in the first trimester, at delivery, as well as in the postpartum period. But thankfully, these do not translate into over decompensated liver failure. So that's the first take home point, is that pregnancy has its impact on HPV, the virus itself, but they perhaps do not translate into significant clinical events. Let's take the contrary viewpoint. What is the effect of the virus on pregnancy? There are multiple associations which have been shown that the virus, hepatitis B virus, has been associated with preterm birth, gestational diabetes, especially in E-positive disease, low birth weight, fetal distress, ICP. There are some contradictory results on PIH and macrosomia, which is again to be adjusted because of the presence of gestational diabetes. But the point to remember again out here, that these are all associations. There's a lot of confounding factors which have not been validated, and the studies have not been properly designed to address these questions. So coming to mother-to-child transmission, the cardinal point of hepatitis B is that if you get it as an adult, the exposure, your rates of transmissions of your contracting the disease around 5%. But the same thing when it happens in infants, because of their immune system, it is up to 90%. So there are three potential areas where during pregnancy or in the peripartum period you can have. There is a lot of debate whether this concept of prenatal or intrauterine transmission of Hep B takes place. There are two schools of thought. One says that this doesn't occur, but then there's another school which says that this does. But the major route of transmission is the natal period and the postnatal period. That forms the basis of your current day therapy for immunization as well as vaccination of treatment of children born with hepatitis B, which can prevent this mother-to-child transmission in 85 to 95% of the cases. So why do we need antiviral treatment during pregnancy? Hepatitis B is a game of numbers. If you see the guidelines, which I think in the next upcoming talks will decide as to if the cutoff is 20,000 or 2,000, these all come from definitive studies. And the same thing holds true for pregnancy in hepatitis B. If you see these on the left-hand side, that's the cutoff level of around 150,000 that's there. If that transmission rate goes up, as your viremia goes up, your rate of perinatal transmission keeps on increasing. And the second factor which influences it is that your E-positivity disease status. You're more E-positive disease, you have higher rates of transmission, which comes down when you have an E-negative disease. So the two factors which are influencing is one, hepatitis B DNA status, the viral load that's there, and what's your E-antigen status. So again, the second question, why do we treat these patients? This is the landmark paper from NEJM in 2016, which said that if in the per protocol analysis, you treat these patients with high HBV DNA at the recommended levels, you can almost attain zero transmission. So do we have surrogate markers? So there is an emerging thought that instead of doing this HBV DNA, can we only use the E antigen levels? But the problem in India is it's mostly an E antigen negative disease. So there is emerging data which says that you can actually use E antigen positivity as well as quantitative HBsAg as surrogate markers with almost equal reproduction to the HBV DNA quantitative assays and use it for determining therapy. And this has come in the latest 2020 WHO recommendations, where they have suggested that in settings where DNA is not available and if it's an E antigen positive disease, you can use them as surrogate markers. So what do the guidelines say? These are the simplistic summary of the guidelines that has been there. The cutoffs that have been universally accepted over the guidelines have been stable. When do you start treatment? You start treatment at 28 to 32 weeks. What is your choice of therapy? Though there is a recommendation that lamivudine and telbivudine can be used, we never use these in current settings and we are always there with TDF. Breastfeeding is not contraindicated, and mode of delivery, there have been no comments in the majority of the guidelines, but there's no clear-cut recommendations that cesarean section per se will increase or decrease your rates of transmission. So this is the simplified approach that you will have with a patient when you come, with a pregnant patient when you're faced with Hep B. Number one, see whether the patient already has cirrhosis or not. If they have cirrhosis, they become immediate candidate for treatments. If they are already on a drug, which is not tenofovir, switch to tenofovir. If they are not on any drug and they meet the conventional criteria of treatment, which I think would be discussed in the later talks, start treatment. The problem is that if they are not cirrhotic, they are not on therapy and they don't meet the standard criteria of treatment. What do? You test them at 26 to 28 weeks and then decide what's your DNA cutoff levels. And based upon the DNA cutoff levels, you decide whether you treat them or not. And remember, if you're not treating them, keep following them up for a potential of hepatitis B reactivation or flare during postpartum period. There is an emerging thought whether you should treat all. Why not treat everybody at the beginning? So there are papers which are looking into this, and there is also a concept of why not use TAF. We still don't have data or the guidelines which is they're using TAF, but given the safety data of TAF, possibly that's going to be the new drug that's going to be there in hepatitis B management. Hepatitis C, on the other hand, as we have already discussed, has become a simple disease, and we have moved from gastroenterologists and hepatologists managing hepatitis C to physicians who have completely been empowered to manage hepatitis C. But somewhere in the simplification of hepatitis C, pregnancy has got lost. There is a thought process as why not do universal screening, and there's been suggestions that this is the easiest way that you should do it. You can have it as an operationally simpler way to do it, and will identify everybody with Hep C. But then again, there's another school of thought which says that there are no existing measures of treatment. Why to test them? The DAs are not approved in pregnancy, so why to unnecessarily test them? So let's debunk one of those myths one by one. So this is what the standard screening strategy for hepatitis C is, or used to be. But recently, both the ASLD and IDSA have suggested that you do a one-time opt-out testing for any patient who is above the age of 18 years. But if you read through the fine prints of the Indian guidelines, you still don't have this fact coming through at your face. So again, we go back, what are the effects of the pregnancy on the virus? Unlike hepatitis B, pregnancy per se does not influence the hepatitis C virus characteristics as such. But on the other hand, there was an initial thought that the impact of Hep C on pregnancy may be not that much, but that has come out with a large data, and I would like to focus on the left lower corner as to the increased incidences of pregnancy-related complications that have been seen in hepatitis C, and one of which has been very classically associated, that's ICP. This is again a same data which was there, that we thought initially that hepatitis B is the one which causes more problems in pregnancy, but this is a head-on trial of seeing patients with B and C, and they've shown that Hep C induces pregnancy-related complications at par or even more than those with hepatitis B. So the procedures and risks that are there, you frequently get calls about a patient is planned for elective CS or an amniocentesis with the increased practicing of fetal medicine nowadays. So these are the general guidelines that have been provided. Cesarean section has got no association, so you don't have a recommendation for that. Amniocentesis, there is one good quality study which has shown a higher odds of transmission, about 6.7, so you have to counsel. The only definitive indication that has been given is with premature rupture of membranes, when you say that if it is more than 6 hours, you go into an active labor management. Breastfeeding, there's been no association and there is no documented increased risks of transmission. So when does this transmission occur? I think we discussed this in hepatitis B, that when do these transmissions occur? There's a small study from the pediatric group that was there, where they found that you've taken 54 infants, and around 17 of them were PCR positive at less than 3 days. That means there was a transmission in utero. The others became PCR positive either at 3 months or at 6 months, which shows that, again, just like hepatitis B, the most common mode of transmission in hepatitis C is also peripartum. And summation of the meta-analysis data says that if you're mono-infected, the chances are around 6% or 5 to 6%, and if you've got a co-infection, it goes upwards of 10%. So in all these guidelines, we are focused on the pregnant patients, but where do these infants go? As per today, the current recommendations for screening for infants is at 18 months of age. So this is a very elegant study which was done which showed that if you follow these patients if you've got 537 eligible patients, of which only 84 of those were actually tested. And that is what happens in a real world scenario. You have got that mother who was anti-HCV positive, and then you are told that you have to follow up and screen the infant at 18 years of age, but it gets lost somewhere. So this again re-emphasizes the point. That's why in the simplification of all the guidelines that has been there with hepatitis C, pregnancy has somewhere got lost. So the latest data that is there, so what the question that has always been there from every side is that why to treat Hep C in pregnancy because there are no drugs? So the first data that has already come out from Dr. Chappell's group is that they've faced a phase 1 trial data in which they've taken patients 24 to 28 weeks of gestation, a small number of 8 patients, soft leady, Geno-1, treated for 12 weeks, compared to other randomized trial data and seen what the pharmacokinetic data is. And they've found that the AUCs, or the concentration of the drugs in pregnant patients compared to non-pregnant patients, are absolutely similar. So hepatitis C in pregnancy, what do the guidelines say? Test everybody at the earliest, do an HCV and RNA and LFT, watch out for ICPs. If somebody has cirrhosis, counsel them that there are adverse outcomes, reevaluate at delivery for treatment of the mother, test the children at 18 months, recheck with antibodies at 3 years, and we have got approval of therapy at 3 years of age with even Velpa, which has now been approved. So the tale of two viruses in pregnancy. Pregnancy is a high impact time for healthcare access. We have got a significant burden for both the viruses, and both of them have adverse outcomes. In hepatitis B, if they meet standard criteria of treatment, treat them upfront. If not, decide at 28 weeks, depending upon the viral load. For hepatitis C, test them, but don't treat them, and wait for the DAs to break the barrier for pregnancy. Thank you, everybody.
Thank you, Dr. Roy. That was a very comprehensive talk on the viruses in pregnancy. And as you said, the pregnant women are, that's a good time to screen them. So universal screening for hepatitis B is recommended. Even our associations have still not recommended the universal screening for hepatitis C. But in IVF and infertility patients, as we are dealing with the gametes, so in those patients, all we are going for the universal screening. That was one thing. What about if a patient is already on the drugs for hepatitis C and she becomes pregnant? So I suppose all these drugs are teratogenic.
There has not been a proven teratogenicity of these drugs. So if we see, there's one paper, one abstract data from India, and one paper of 8 cases, that's from Japan, which they have shown, they have selected these patients who were already taking these drugs, got pregnant, followed them over, and they had absolutely fine pregnancies. And I think with the phase 3 trial coming up of Velpa, there's no reason for these drugs to be teratogenic in pregnancy. There's absolutely. I think next 2 years, we are going to get these drugs into pregnancy and treat.
Thank you.
One question from my side. Here. Only the take-home message, what I want as an obstetrician, I want to know. If I refer a patient with HCV positive or hepatitis B virus positive, what a physician say of mode of delivery. It's a cesarean section or it's a normal delivery. Because patient doesn't want this dilemma, okay, I want to go for normal delivery or I want to go for cesarean. So as a doctor, I have to say them, okay, you should go for cesarean or you should go for the normal delivery. So what a physician say on this?
So across the guidelines, it's a uniform.
The guideline is always a dilemma.
The decision would be that the mode of delivery would be determined by the obstetric choice and not the viral choice.
Okay.
Yeah, so I can answer that question. So the cesarean in hepatitis B and C is only for obstetric reason. And yes, if you have few patients with hepatitis B with concurrent HIV infections, then we do go for C-sections in those patients.
Yes. So thank you. For the sake of time, we move to next session. Thank you, Dr. Akash Roy. I think it was one of the most simplified lectures for today.
Thank you, sir, and thank you, chairpersons. Next topic, that will be a debate on HbSAg positive should all be treated. For that, I would like to invite Dr. Ram Pariyar, sir, Dr. Pathik Parikh, sir, Dr. Pankaj Gupta, sir, and Dr. Sagar, sir. The speaker will be invited by the Honorable Chairperson.
Good evening, everyone. So today's topic is HBsAg positive should all be treated. It's a debate, and it is done by Dr. Anil Arora, sir. He needs no introduction. He is one of the most renowned hepatologists in India. So I'll give the floor to sir.
Thank you, sir. At the outset, I'm extremely grateful and thankful to Dr. Yogesh for giving me this opportunity. I do not know whether my worthy opponent, Dr. Dharmesh, is going to join for the motion. But in any case, I can, if he's not available, I can join and give you the arguments for both. The topic of presentation is, should all hepatitis B patients be treated? My job is to talk about the motion. Now, what is the immunotolerant state? As Dr. Akash Roy just told us, that whenever you get infected at birth, something happens, and it is believed that HBe antigen is an agent which tends to induce the tolerability of the immune system. If there is no E antigen at birth from the mother to the baby, I think people will not get chronically infected. And now it is believed that if you have anybody who has a replicating virus, normal histopathology, and normal enzyme, that means this patient is something which is immune tolerant. And somehow it takes the human body another 2 to 3 decades to get over this tolerance. That means the tolerance breaks at the age of 30 years, when the body starts mounting a response in which you tend to develop immune active hepatitis. This is how we try to classify the type of hepatitis B virus which we see today. So rather than calling them different types of hepatitis, we try to characterize as hepatitis E antigen positive or negative hepatitis. And depending upon their DNA, HBe antigen status, ALT and the liver disease, we tend to call them as E antigen positive chronic infection or hepatitis. Chronic infection would entail that you just have a replicating virus, there is no injury to the liver, biopsy is normal. And these are the subgroup of the patients who are called immune tolerant. And I think Dr. Yogesh has specifically kept the debate for this subgroup of the patient. If you have any virus which is causing inflammation, leading to raise in the enzymes and as well as injury in the liver as documented by pathology, certainly you need treatment. There is no confusion about that. Similarly, in chronic E antigen positive state, chronic infection would mean you have low replicative virus. This is a subgroup of the patient which may need treatment. And anybody who has an actively replicating virus, even in E antigen negative state, does certainly need treatment. So I think the debate primarily is circling around this subgroup of the patient called so-called immunotolerant phase. And how do we define what is immunotolerance? And how do we define what is the normal ALT? In fact, there has been a lot of debates and discussion in the hepatology arenas regarding what is normal and what is abnormal. In fact, ASLD and EASL have taken these two definitions of what is normal and abnormal ALT. If you look at the various guidelines which tend to have a different cutoff for treating hepatitis B, they are different in ASLD, EASL and APASL. They take different cutoff for treating hepatitis B patient. So if there is no consensus amongst these big 3 international guidelines, so how the hell can we have the consensus in our own single gathering in, say, Ahmedabad? And if you look at the non-cirrhotic E antigen positive patients, if ALT is normal, it is said that you should not treat it. But if the ALT is high or if the DNA is high, you certainly need treatment. But then there is again a caveat in this subgroup of the patients who are not recommended to be treatment, is that these patients with significant fibrosis may need treatment. So there are increasing indications for trying to give treatment even in patients who have normal ALT. So look at this middle graph. If ALT is not more than 2 times the upper limit of the normal, you are supposed to do a fibroscan, and if the patient has a substantial fibrosis, even with normal ALT, and DNA should be treated. And secondly, there is a candidacy for treatment. It is said that if ALT is more than 2 times the upper limit of the normal, treat it. Who decides the candidacy of this? What is the relevance of 2-time elevation in ALT? Does a normal ALT mean that the patient has a normal liver? Let me give you some starking data. Now this very concept of giving it, asking for a 2-time elevation in ALT came from very old studies in which interferon response was judged based on the ALT assessment. But that is an old concept. But if you look at the current data published from ILBS, Dr. Sarin's group and other studies, it has been shown that even in patients who have so-called normal ALT, that means you think the patient doesn't have anything. If you do liver biopsy, at least 30 to 40% of these patients have a substantial liver disease. That means the normal liver function test or a normal ALT does not rule out a substantial underlying liver disease. Another study again shows that even in those patients who are considered to have normal ALT, as many as 40 to 50% of the patients may have a substantial significant fibrosis. That means they have been having significant liver disease even though your parameters in the blood do not reflect the same. What about the possibility of developing cirrhosis in patients who have no ALT? Guidelines say ALT is normal, just follow them up, do nothing. But see what happens. This is a subgroup of the patients who are having normal ALT. With passage of time, most of these patients are going to have progression of the disease. It is just a question of time. As the age increases, as the time passes off, the chance of cirrhosis and the complications are likely to increase. Both the incidence and the occurrence of cirrhosis of the liver as well as hepatocellular carcinoma is a test of time, it is a parameter of time, and with increasing passage of the time, those patients, even with normal ALT, are likely to have development of the cirrhosis and hepatocellular carcinoma. In fact, there was a study published from California which looked at the patients who were left alone because the guidelines would not recommend treatment. And when these patients were followed up over the next 10 years, 50% of the patients died of liver disease in the form of either cirrhosis or HCC. Just because of the flimsy reasons of a normal ALT or HBV DNA of 20,000 or 18,000, if you leave them alone and follow them up, 50% will die of liver disease which could have been prevented at that time. And the best example comes from this most widely quoted study called REVEAL study from Taiwan. This is a group of the patients who were having HBsAg in inactive state and they followed up over a period of time. These were the patients in the age group of 30 to 60 years with normal ALT. These studies will never be repeated. This is the best ever study published in hepatology till date. And look at the cumulative incidence of cirrhosis with passage of time. If you look at all the patients, the DNA is the most important parameter which tells you when are you likely to have cirrhosis of the liver. Higher the level of the DNA, more the chance of having cirrhosis of the liver. And if you look at the progression of the disease, HBe antigen positive patient with DNA has, even if the ALT is normal, asymptomatic patient has the highest chance of developing all complications of the liver, including cirrhosis of the liver. And if you look at in the same study, there are two parameters which had looked at the risk factors in untreated patient for a long period of time because of the presence of the hepatitis B. And it clearly shows two factors which decide whether you are likely to develop hepatocellular carcinoma or not. It's E antigen positivity. And mind you, ALT was normal in this subgroup of the patients. So a normal ALT also puts you at a higher plateau of developing hepatocellular carcinoma in patients with cirrhosis of the liver. And look at this incidence of hepatocellular carcinoma in patients who had a normal ALT and were left untreated. Anybody with high DNA of more than 1 million has a 14 times more risk of developing hepatocellular carcinoma, both in E antigen positive and negative state. So, and it also clearly shows this REVEAL studies that if you have a high DNA, you have a very high chance of developing hepatocellular carcinoma. In fact, there is a mathematical, geometrical relationship between the degree of rise in DNA and the incidence of hepatocellular carcinoma. So, ladies and gentlemen, minimally elevated ALT or a normal ALT does not give you a clean chit or a clear answer that you are not going to develop a chronic liver disease or hepatocellular carcinoma. Moreover, if you look at the number of the patients who have normal ALT and the substantial fibrosis as seen by fibroscan reading of more than 12, 10% of the patients have substantial fibrosis even with normal ALT. So that means normal ALT and degree of liver dysfunction, that is persistent and permanent injury and scar to the liver do not go hand in hand. So this was the first editorial which mentioned that we should challenge the notion that only those patients with replicative virus and ALT should be treated, because we have enough data to show that even those with so-called normal ALT, unless you do a liver biopsy or a fibroscan, may be left untreated. There is another publication from Korean group, which would again look at the same group of the patient, which as per the APASL, EASL and ESLD guidelines were left untreated. And if you look at the hepatocellular carcinoma, death or transplantation, it was substantially high even in patients who were in the immune tolerant group. That means immune tolerant group was not an innocent or innocuous group, it had a substantial risk of development of hepatocellular carcinoma. And another very important observation in this follow-up cohort study from Korea clearly shows that both the hazard ratio of death or hepatocellular carcinoma was the same both in the immunotolerant group as well as minimally active phase of the disease. That means whether you have immune tolerance or whether you are having active disease for which treatment is recommended, or in immune tolerant in which it is not recommended, risk of death is same and risk of development of hepatocellular carcinoma is the same. So why is it that immune tolerant and HCC, is it the time that we should need to revise our indications for treatment? In fact, this is another Korean study which has shown that even in patients who are supposed to be immunotolerant, if you look at their histopathology and look at the integration of the virus in different time frames, the degree of the viral integration, the degree of immune dysregulation and degree of genetic dysregulation was equal in those who were having chronic active disease versus those who were immunotolerant. That means once the virus has entered the body, as Kaushal was showing, this is the virus which tends to get integrated into the chromosomes of the human genome. So longer it stays, the more likely it is going to induce changes which may be near the tumor suppressor or tumor activator genes. And it is just a question of time that with passage of time, you may have higher risk of hepatocellular carcinoma. Does TDF or the conventional treatment as shown by Akash, which is the standard of care for treatment of hepatitis B, does it decrease fibrosis? There is good data to show that patients even with minimally elevated ALT, if they are put on long-term therapy with tenofovir, there is a substantial reduction in the degree of the fibrosis. That means compared to placebo, these patients are less likely to have severe fibrosis if given over a period of time. And consistently, all these patients do have suppression of the virus. Look at the DNA, which plummets down to almost nil level once the patient is on antiviral therapy. So these new antiviral therapy like TAF and TDF are potent suppressants of the virus which can be given safely in these patients. All these studies have consistently shown that if you give nuke in patient with chronic hepatitis B, there is at least 3 times reduction in the risk of hepatocellular carcinoma. Why is it that ALT may not be a good parameter for the virus? Once is a virus, why not treat it? The problem with treatment with hepatitis B is, as of today, I'll just take 2 additional minutes. As of today, we do not have good drugs to treat hepatitis B which has got integrated into the genome, as Kaushal has very elegantly showed, that if you give direct acting antivirals for hepatitis C, the virus resides in the cytoplasm, you get rid of it. So you have a cure within 6 months. Hepatitis B is a unique virus which tends to get integrated into the human genome. So you cannot alter the genome. That is the reason it keeps on producing a large number of the DNA and RNA copies of the various components of the virus. So this is the basic difference between hepatitis B and C. As the virus enters into the cell, after getting decoupled and de-enveloped, it tends to enter into the nucleus. And there is data to show that even within 24 hours of acute hepatitis B virus, the virus can get integrated into the host genome. And once it gets integrated into the genome, it can produce both cirrhosis as well as the development of hepatocellular carcinoma. And it has been repeatedly shown that replicative virus and the DNA are the most important factor for causation of hepatocellular carcinoma. Look at this geometrical relationship between the incidence of HCC and the degree of rise in DNA. The higher the DNA, the more chances of developing hepatocellular carcinoma. A DNA level of more than 100 million unit has a 300 time risk of developing hepatocellular carcinoma. So, if you look at what is happening, learning from all these experiences which are anecdotal, look at the increasing in variable indications by different international guidelines. Now, guidelines which were saying that do not treat patients who are having inactive virus, now they have included this group of the patient who are more than 40 years by ASLD or concomitant significant fibrosis by ASLD. Similarly, EASL has come down to an age limit of 30 years, that up to 30 years all patients should be treated. And then if you have a concomitant fibroscan of more than 12, you should treat the patient. If you look at the trend, the increasing number of the patients are included in this paradigm of treatment rather than leaving him alone. So, whatever we do, otherwise if we tell the patient that you don't need treatment, it is possible that the patient will be left alone. If the patient is left alone, so many patients may come down to you later on because they think they are normal, they do not need any treatment. And later on they can come to you with ominous complication of cirrhosis and portal hypertension. So these are the arguments which Dharmesh may like to give and counter argue with me, but I think I leave it to him. Our argument for treatment is that good prognosis in short-term intermediate area may not be enough in patient with hepatitis B. What you need to do is a long-term suppression of this so-called oncogenic virus. If you have a drug which gives you a persistent long-term suppression of the virus, this is a drug which should be welcomed. Patients with normal ALT do not have an underlying normal liver disease. So our indications are, we should give universal prophylaxis. These are the established indications. Before immunosuppression to all patients. Akash has shown that if you have a high viral load and you want to prevent MTCT, you have to give it in patient with the pregnancy also. All patients with extrahepatic manifestation should be treated. All health workers with hepatitis B should be treated. In other clinical setting, we should treat all patients with hepatitis B to reduce the infectivity. So rigid adherence to the arbitrary ALT cutoff should not be key to the decision of to the important decision making in treatment of hepatitis B. Patient with normal ALT should be offered treatment after discussion of advantages and disadvantages. As of now, all patients more than 30 years of age, all with cirrhosis, all with family history of HCC, or with comorbidities, extrahepatic manifestation, and should be treated with for treatment with hepatitis B. And patient with mildly elevated ALT should be further investigated to rule out an underlying liver disease. So ladies and gentlemen, to sum up, I think the old management of hepatitis B, including the current guidelines, did tell us treat only patients who fulfill the criteria. But my recommendation is treat all the patients unless there is a contraindication not to treat the patient. With that, I'll stop giving arguments for and leave it the floor to the.
So I request you to please take your seat, sir. Dr. Dharmesh Kapoor has joined. Yes, sir. Welcome, sir. Good evening, sir. Yes, sir. You're audible, sir.
And is the screen visible? Are my slides seen?
Yeah, it is visible, sir.
So, are the slides seen?
Yes, sir. Yes, sir. They are seen, sir.
I'll move them just to be sure that, yes, okay. So, good evening, everyone, and apologies that I can't there be in person, and thanks so much, Yogesh, for this invite. Fortunately, I was able to hear most of what Dr. Anil said, though I couldn't see his slides. So, I think his point is well taken that more and more people are coming under the ambit of treatment for the diagnosis of chronic hepatitis B virus infection. In fact, those of you who have a discerning eye might with chronic hepatitis B virus infection be treated. So there is a difference between a subject and a patient, and that is the first point I would like to make. So we all know that this is a humongous problem that faces the medical science as well as humanity. There are close to 260 million people who are infected with this virus worldwide. The WHO has set a target in 2016 that it wishes to reduce the infection rates globally by about 90% and the associated mortality from hepatitis B virus by greater than 65%. So how do we think is this going to happen? Do you think it is going to happen just by treating every single person who is HbS-Ag positive? In fact, the topic of the debate was whether everyone who's got an HbS-Ag positivity of greater than 6 months should be treated or not. Though I agree with most of what Dr. Anil has said, but then there are certain things which will tell me that our treatment approach has to be more nuanced and not a hammer and tongs kind of approach. Now let us see what is the best case scenario. So we are all talking of what is called as the functional cure. So this is the best achievable treatment outcome that we have right now with the available drugs. I think the biggest the biggest relief for the treating community has come from the fact that there are 2 orally high barrier to resistance against the hepatitis B, and I will come to a minute in that why that defies the microbiologic dogma. These drugs are safe, they are cheap, they are pretty efficacious, and because of all these reasons that I just enumerated, the treating community feels that they could paint everybody with the same brush, meaning that anybody who's sitting in your clinic with a hepatitis B surface antigen positivity of more than 6 months, he is a guy who's worthy of treatment and you will initiate this treatment. And what are we achieving by this? We are achieving what is at best called the functional cure, which is someone who's got surface antigen negativity, HBV DNA negativity after a finite treatment course. So that is the basic definition of a functional cure, and here the finite is extremely important because we must learn and pick cues from the other aspects of clinical medicine. What we actually want, of course, is a sterilizing cure. Sterilizing cure is the ideal treatment goal, and this means that any way in which the virus might be archived in the human host, and that is the only way we will be able to prevent the complications that Dr. Anil just enumerated, mainly progression to advanced fibrosis / cirrhosis / HCC. And this will happen when there is a loss of the covalently bound circular, covalently closed circular DNA and the integrated HBV DNA plus the restoration of the hepatitis B immunity. So both these 2 components of the definition are extremely important to achieve the sterilizing cure. And in how many can we achieve a functional cure also, which is far removed from the sterilizing cure? That answer is at best 10 to 30%. That means in only about 10 to 30% of patients, when you have treated them even for a period of over a decade, you will be able to achieve the surface antigen negativity. So what are we discussing over here? We are talking of an infinite amount of treatment or duration of treatment for most of our patients. Now, this particular table tells you the whole story. So both for the E antigen positive as well as E antigen negative patients with chronic hepatitis B, most of these patients would have fulfilled the criteria for treatment across the various guidelines that you might wish to follow. And you can see that the best rate of surface antigen seroclearance, mind you, this is not anti-HBS positivity, this is only surface antigen clearance, can be achieved by pegylated interferon. I wish we were still living in that era, and then very few of our patients would come under the ambit of treatment. But because we have the lower 3 drugs available to us, everybody feels extremely confident that yes, you write a prescription for these drugs and everything would be fine, and this patient's hepatitis B is going to be taken care of. Now we all know, and we should not delude ourselves, that the course of hepatitis B infection, even when it becomes chronic in a given host, depends on a number of factors, and this table is not complete in any way. So it is the age of infection, the route of infection, the status of the E antigen, the surface antigen quantification, the DNA quantification, the genotype of the virus, and the transaminases, which Dr. Anil alluded to in some detail, as well as liver histology. So, like I said, this is not a complete table, but these are the various determinants, both from the point of view of the virus as well as the host, which are going to define the outcome of a given patient's treatment. Now, for those of us who swear by the guidelines, you can see that these are the guidelines. I've tried to take them all in one table, whether someone who's E antigen positive or someone who's E antigen negative should be treated. So we know that there are various phases of this now. There is someone who's immune tolerant, which is a small chunk for us. It's less than 10 to 15%. These are people who are E antigen positive, near normal transaminases. When I say near normal transaminases, these would be transaminases in the late 10s and early 20s. They have got hardly any fibrosis or necroinflammatory activity when you biopsy them, and these people are asymptomatic and E antigen positive. Then you have the immune active group, which is E antigen positive and E antigen negative. These are the ones that we oftentimes treat in our clinical practice. The E antigen negative outnumbers the E antigen positive in our country to a ratio of about 2.52:1. And we find that these patients will have some degree of elevation of enzymes, necroinflammatory activity would be there, and non-invasive or liver biopsy markers would suggest fibrosis. And these are the ones that we treat. And then you have those patients in whom the surface antigen is positive, the DNA is less than the threshold for treatment, the liver enzymes are near normal, and if you were to biopsy them, at least a proportion of them. So he told you that the glass is half filled, I will tell you that the glass is half empty. So in the study of P0, which was published from G.V. Pant, which we had initiated and then went on to be published in its full form, it's only about 30 to 40% of patients who would have some degree of histological activity. That means bulk of these patients still would not have significant histological activity. And then of course there is no argument in treating cirrhotic patients, and I completely agree with Dr. Anil that here we should not be bogged down by the guidelines. Any ALT, any DNA value, if you have got F3, F4 fibrosis, either on non-invasive tests or on liver biopsy, you should be treating these patients. But this is what you see. So how many monitors do you see in this? So that means these are people in whom you need to just monitor them, but you might not treat them. There is a large chunk of patients who constitute the gray area. So gray area means that either the transaminase value wise or the DNA value wise or the inflammation or liver fibrosis value wise, they would not fit into any of these categories. So I myself don't want to be bogged down by the guidelines, but then it's also very important that you are trying to treat a huge population load with drugs that you think are very safe, very effective, but whose adherence is always questionable. So the gray area is a huge chunk of patients, about 20 to 30% in our practice, and for them too what has been suggested is that we should monitor. Dr. Anil dwelt to some extent on the REVEAL data, which was the first eye-opener for us, which told us that yes, if you have got a very high baseline viral load, these are the patients who are going to develop advanced fibrosis/cirrhosis. And look at what the immune tolerant group tells you. So the immune tolerant group of chronic hepatitis B, it most closely follows the REVEAL wisdom. That means very high viral load, and you're talking here of 10 to the power 7, 10 to the power 8 international units per mil. But these patients have got hardly any inflammatory activity. And there are studies from the Eastern Hemisphere where it has been shown that if you try to treat these patients, even with the best available nukes for a period of 5 years, you will find that the moment you stop the nukes, almost all of them are going to come back to the original status. And in fact, more than 2/3 are going to need a retreatment. So that means you started to treat them thinking that these patients would be helped by that, but it does not shift the clock. It does not shift the clock at all. And in fact, it has also been shown in some studies that proportion of these patients would spontaneously seroconvert and then later on naturally might become S antigen negative. And this number is greater than the number of S antigen negativity that you will be able to induce if you were to treat them. So I think we must understand that if you have someone whom you are seeing in their 20s or early 30s who's got normal enzymes, normal non-invasive tests of fibrosis, very high viral DNA, these are the patients who are left just on follow-up, left alone and not offered any treatment. Now, what are our gaps in knowledge? So these are two that I could think of, that we think that patients who are lemivudine or telvivudine naive, in them the ETV resistance or entecavir resistance is not known. Again, there is some confusion about what dose to use in someone who's been exposed in the past, 0.5 or 1. And second, that in mono-infected patients, TDF and TAF resistance is not known. But we really do not know because there is hardly any literature in this particular domain in the recent years. And have we ever looked at the genotypic resistance in those patients in whom we have start-stop phenomena, which is extremely common? By start-stop phenomena, I mean that these patients are treated for a while, then you stop treatment. When these patients come back again with a biochemical or a clinical recrudescence, then you start to treat them again. So I am sure that if you were to take a leaf out of the microbiology books, they will tell you that there would be some level of genotypic resistance, though it might not actually also translate into any clinical significance. Now I will leave you with two case scenarios, and I would request my good friend Dr. Anil Arora to say whether he would want to treat these patients. So this is a 26-year-old primey who's tested surface antigen positive during first antenatal visit. Her DNA quant is 2,500 international units per mil. The ALT is 19, the liver imaging and the non-invasive test of fibrosis for whatever they are worth. I know they have not been well validated in a pregnant state, they are all normal. At 28 weeks 2, the DNA is only 2,000 international units per mil and her LFTs are normal. So are we going to treat this lady? And let's look at another scenario. So where is the paradigm shifting now? So now we are talking about finite duration of treatment, because it has been seen that those people who have been able to achieve a significant repression or suppression of the viral DNA, in them you might give a trial of stopping treatment. So let us look at this case scenario. So this is a 45-year-old male businessman treated for E antigen negative chronic hepatitis B with TAP for the last 5 years. He achieved his DNA quant target not detected within 6 months of the onset of treatment. At 5 years, his surface quant less than 100 international units per mil. The treating doctor, who is a famous hepatologist, and mind you, this is a real case scenario, wishes to stop nukes with a view to induce a surface antigen loss. So here what we are building the premise is that if you stop the nukes, these patients will have a kind of a immune reconstitution, development of the virus immunity is going to come back, and a proportion of them might be able to clear their surface antigen and hence achieve a functional cure. So theoretically and pathophysiologically this sounds as a very valid concept. But 3 months later his DNA has gone up to 3,500, the LSM is 6 kilopascals and the ALT is 65 international units per liter. So would Dr. Anil want to treat this patient? So these are the scenarios which we see in day-to-day practice, and I think my final take would be that even though I concede that more and more patients are coming under the ambit of treatment, in clinical medicine, dogma that I shall treat everybody should play second fiddle to rationality. I will treat only those who are likely to benefit. And it is also very important to remember as a lesson of life, not just management of hepatitis B, that if you are carefully careless, that means not treat, monitor, keep under surveillance, rather than carelessly careful. Treat just because surface antigen is positive, but fail to recognize the adverse effect of nukes and miss HCC surveillance. I am absolutely certain that Dr. Anil Arora, in his vast experience over decades, would have seen people who are just on one of the two nukes, have tested surface antigen surface antigen positive but DNA negative, and they are established serotics at the time we initiate treatment, and they will go off the radar and they will come back to you again with the HCC. So I think the most important aspect of this is not to give them a drug to curb the DNA, but to tell them and educate about how this virus behaves in a given individual. Thank you so much for your attention, and I would be very happy to hear his rebuttal.
Thank you, Dharmesh. First of all, let me make something which is very clear. First of all, there is no confusion about our goalposts which are changing. Dharmesh, you should remember the patient has come to you for management of hepatitis B surface antigen. And that is the last thing we want to talk as a hepatologist. We talk of ALT, we talk of DNA, we talk of E antigen. Have we talk of HBsAg? Upfront we tell them very clearly at the time of presentation that HBsAg is not likely to go. What we are trying to suppress is inflammation. What we are trying to suppress is DNA. And think there is enough evidence for that. Because we do not spend enough time explaining them, he has not come to you for E antigen, he has not come to you for DNA. These are the additional tests you are doing. So let's not compare the thing. And why are we in a very big hurry to stop the therapy? Have you ever stopped the therapy in diabetes? Your example that somebody has stopped it and then the DNA has gone up. If somebody is on insulin or with diabetes, you stop insulin, won't the sugar go up? It's just question of our own timing and explanation and sitting with the patient that this is a drug which will not get you cured but is going to suppress the inflammation. And show me one patient who has been on regular, other than cirrhosis, that another example which you have given is cirrhosis per se is an oncogenic state. Even with or without viral replication, the fact that you have cirrhosis of the liver, I think Kaushal has presented that data. Or even after development of the cirrhosis, even if you have cleared the virus, B or C, you are likely to develop HCC. So surveillance is needed. So your argument that everybody has to be on constant surveillance and somebody to be sure of that, it is just like saying that you have all politicians, nobody indulges in corruption. That is not a realistic state. Let us accept it. If it is politics, it has to go by that. There can never be a politics without corruption. Otherwise, you can never be a politician. Let's be honest about it. The fact that you cannot go there, the fact that we do not explain the patient that you are getting rid of HBS, not getting rid of HBS-AG, you are only suppressing inflammation, you are only suppressing DNA, you are trying to normalize ALT. Let's never be in a hurry to keep the patient on surveillance. So many times, because of our lack of spending time with them, we tell the patient ki sab theek hai. Patient will come back to you. I'm sure everybody would have seen the patient with first presentation at the HCC, because nobody spends time. So it's better to put in a drug like this. But I fully agree with you, there is increasing gambit of the patient who needs to be treated. But at the moment, our problem is that we do not have good drugs to treat the integrated virus. Tell me, Dharmesh, if tomorrow you have a drug which can get rid of the integrated virus, would you treat or not? It is a virus which has an oncogenic potential.
So I think you are probably now speaking from my side. So that's
both sides. It's for the benefit. It's not for your or my benefit. It's for the benefit of all the physicians.
So that's what I said. So I think because this discussion can go on and on. So I think the important thing to remember is the adherence. So whenever we are advising anybody a long-term treatment, so like you took the example of diabetes. So you know as well as I do, there are many people who skip their doses and they don't even bat an eyelid. They would think that it's a perfectly normal thing to do. Even in treatments which last for very short durations like tuberculosis, even the WHO guidance is that if somebody is taken more than 80% of the time of the scheduled treatment, that is good enough. And there were studies on the nukes with respect to adherence only in the LAM, Adefovir and LDT era. They are now very few or far between, and I couldn't actually lay my hands on any in recent years. And again, that is something that we as clinicians should probably be paying more attention to. So this particular thing which I told about stopping the nukes is a very common phenomena. There are 3 large trials and which have all come in high impact journals where people with E antigen negative chronic hepatitis B, there have been effort made to stop the treatment and to see if they would lose the surface antigen. And a proportion of the patients do lose the surface antigen, which is again because the body's, the host immunity against the virus is reactivated. So here the catch is that you do not allow the enzymes to jump too much. Look for the features of any clinical flare. And also, if we were so obsessed about somebody coming to us just with a surface antigen positivity, then why do we do the E antigen and DNA at all? So I think it is as much a job to write a prescription as to educate the patient that it is not the surface antigen which is going to harm you, even though you have come looking for a cure for that, but it is something else which damages the liver. So just to end this discussion, if there is a 16-year-old who walks into your clinic who's got a DNA of 10 to the power 8 and ALT of 14 and a normal ultrasound, would you want to treat him?
Dharmesh, I'll agree. Anything less than 20, I'll give you full points. No treatment, immunotolerant. Done. Yes. But
So
let me comment your article on HBsAg attempt to get rid of it in the patients who have been on long-term immunosuppression. If you study this meta-analysis recently presented by Dr. Nora Tollett, 20% of the patient had exacerbation of the disease. And there are so many strict criterion to adhere to that. That means you are having E antigen negativity persistently for a period of 3 years. Your DNA is persistently negative for 3 years with normal ALT. How many of your patients can achieve that? How much of the surveillance can you do? And even if you get clear of HBsAg, integrated virus is still there. I do not see any reason why are we in an E antigen patient making a big hurry to get rid of HBsAg, knowing very well that you cannot get rid of the integrated virus, which will again going to pop up DNA and RNA and so many X antigen across the road because you're not getting rid of it. And 20% of the patients in these 3 studies which you have quoted, they had exacerbation of the disease which may have fatality.
It's yes, it has to be done in a select group of patients. Completely agree.
So for the sake
It's really
of
a phenomenal debate.
Yeah.
It was really a phenomenal debate. But one concern, 8% of our population means 10 crores of Indians are having this CHB or HBsAg positivity. And if you are offering all of them this antivirals, how many will develop this resistance?
Yeah, can I answer? Yes, I'll answer that. First of all, this figure is wrong. 8% is not the prevalence. If you look at the current data, prevalence is around 1%. So let's make it very clear. Secondly, we have been debating which patient should be given. I think Dharmesh will agree at a cutoff of 20 or 30 years. If you can ensure, see, he has made it very clear, if you can ensure patient will come for regular follow-up, he will have DNA, he will have ALT, which is easier. At beyond the 30 years, all patients should be given, even EASL says that, less than 30 years, if there is a perinatal transmission, if you can ensure that he'll come for regular ALT checkup, regular fibroscan, ultrasound, DNA, then you can jolly well withhold. But how many patients will come for adherence? Dr. Akash has shown the data that even after knowing that HCV is transmitted transplacentally, only I think 4 of the 84 patients were tested later on because you forget later on. So if you say everything is normal, it suits the patient, they'll not come back for follow-up. So that is the caveat. Short of that, 30 years, raised fibroscan, comorbidities, everybody should be treated.
So, thank you, Dr. Anil and Dr. Arora. Thank you, Dharmesh sir, for joining in spite of your busy schedule. You were traveling and you are here with us. Thank you so much, sir.
Thank you. Thank you.
Thank you, sir.
And have a great evening.
Thank you.
Wishing all the colleagues in Ahmedabad.
Thank you,
Yes.
sir. Thank you.
Now we'll start NAFLD fatty liver sessions. So for this first topic is management of fatty liver in 2022 and 2023. For that, I would like to invite Dr. Bhagirat Solanki sir, Dr. Kartik Desai sir, Dr. Apurva Shah sir and Dr. Kunal Bhardwaj sir. As a chairperson, the speaker will be invited by the honorable chairperson.
Good evening. Congratulations, Dr. Yogesh, for successful fourth Gastro Summit. And I compliment him for keeping the topics which are really interesting for practicing physicians and the resident doctors. So that is why we see the house full of audience since the conference began. Dr. Pathik Parikh is more than a decade. He is practicing as a gastroenterologist in Zydus Hospital, and he has wrote many articles and books. And he is going to talk on the topic of management of fatty liver in current time, 2022 and 23. Over to Dr. Pathik Parikh.
Thank you, sir, for your kind introduction. Just before I start, I need to acknowledge that this week, the INASL or Indian National Association of Study of Liver Disease statement on treatment of fatty liver disease has been published, and Dr. Kaushal Madan, who is present amongst us, is one of the authors of that article. So, before I start, we all know that fatty liver disease is very common, and nearly 1 in 3 Indians are expected to be suffering from fatty liver. So being able to treat that adequately is of utmost importance. But what has happened over the last 2-3 years is there is a debate going on, what should be called this? Non-alcoholic fatty liver disease. So in non-alcoholic fatty liver disease, we exclude anybody who has significant amount of alcohol. So a new terminology is being proposed. There are proponents and opponents of this terminology, and that is MAFLD, metabolic dysfunction associated fatty liver disease. And there is a growing consensus, although in the Western world, to label not NAFLD but as a MAFLD. And that leads to further new terminologies. For example, a person who is overweight and is taking significant amount of alcohol, the disease is called SMAFLD, and if they develop steatohepatitis, it may be labeled as SMASH, other than the NAFLD or the alcohol-associated fatty liver disease. So this is about the terminology which is maybe seeing some change in the next coming year. Now we all know about the history of the NAFLD, that it progresses from simple steatosis to steatohepatitis to fibrosis to cirrhosis, and HCC may develop at any point of time. So the reason why we need to know about the natural history is to identify people whom we need to treat. Ideally, not all patients with fatty liver needs to be treated by pharmacotherapy. Only lifestyle modification and modification of risk factors is required when they are having just steatosis. And only we need to treat patients with steatohepatitis, with or without fibrosis, and once they develop cirrhosis. So anybody whom we are suspecting NAFLD, the next step is always to identify or look at the underlying risk factors like diabetes, obesity, dyslipidemia, obstructive sleep apnea, to rule out a history of alcohol and to rule out other etiological factors. One of the important factors is getting an ultrasound. Now we all get an ultrasound for when we are suspecting a fatty liver disease, but ultrasound only tells us about fatty liver. It does not tell you whether there is steatohepatitis or fibrosis in this patient, and the level or the grade that they mention is about the amount of fat. So fatty liver grade 3 does not mean it is a stage 3 fatty liver disease. It is a grade 3 is the higher amount of fat content in the liver. So ultrasound is not a test to identify patients whom we should be treating or not treating. Just to identify fat, there is a fatty liver index which has been proposed right from nearly 2 decades back, and it is now easily available, and we can use as an alternative to determine the amount of fat in the liver. But just knowing the fat is not important. What is important is knowing whether there is presence or absence of fibrosis, because it has been shown that if there is fibrosis, there is development of complication, and without fibrosis, the complications are not there. So our target is to identify that one person from the patient, 100, who is likely to be suffering from fibrosis in association with fatty liver disease, and to target our treatment to these individuals. So the routine parameters that people are monitoring is ALT and ALT, but it is not adequate. People with steatohepatitis may also have a normal ALT, and abnormal ALT does not mean that it is associated with steatohepatitis. So just knowing liver enzymes is not adequate. So there are other tests which needs to be carried out to understand and identify people who needs to be treated. Ideal world, it is liver biopsy, but we know that liver biopsy is not possible, and that is the reason non-invasive tests have been recommended to identify patients with significant fibrosis. Now, we come across all the fatty liver who have been referred for elastography, but I'll just concentrate that you don't need elastography in all patients. You need what is called, there are very simple tests available which you can do on your own clinic to identify who are high risk for fibrosis. And they are FIB-4 score, NAFLD fibrosis score, or APRI index. They are very good negative predictive values. They just require a complete CBC and an LFT, complete LFT, to be able to calculate these scores. And once you calculate these scores, if they show no fibrosis, there is hardly any need to refer these patients to a tertiary care center or a super specialist for management of these patients. And these are freely available on internet. NAFLD fibrosis score and a FIB-4 score, you can easily calculate on your mobile using an internet connection. Recently, a new model has been proposed, and every day we come across different models which are being proposed, but this recent publication has shown that it is better than even elastography, equivalent to elastography in predicting fibrosis. These simple scores tell you that there may be amount of fibrosis. That is when we advise a second step to confirm this investigation, and fibroscan or vibration control transient elastography, what everybody is aware of. But not everybody has an access to fibroscan machines, or even an alternative that is a fibrotouch machine. Nowadays, even a routine ultrasound machine is equipped with calculation of point shear wave elastography, and there is emerging data that point shear wave elastography is equivalent, that values correlates with fibroscan values. So after getting this simple scoring system, if you predict fibrosis, if you suspect fibrosis, you can proceed by getting either a shear wave elastography or a vibration control transient elastography. There is MR elastography, which is very high end, not available I guess in Ahmedabad as of now, but it may be considered as well. Once you know that this patient has steatohepatitis and this patient requires treatment, that is when you start targeting treatments. The most important aspect of treating a fatty liver disease is weight loss. I would not go into the details about the endoscopic management and the bariatric management of weight loss, which Dr. Yogesh Harwani is likely to cover. We need to treat the underlying risk factors as well, that is diabetes, dyslipidemia, hypertension, and then we need to direct treatment at the liver steatohepatitis. As of now, only 3 treatments treatments are recommended by Indian National Association of Study of Liver Disease. For non-diabetic patients, it is only vitamin E. And for diabetic as well as non-diabetic patients, we can consider pioglitazone or saroglitazar. So these are the only 3 treatments as of now recommended by INSL. But as we are talking about 2022-2023, so in the upcoming years, I would just go through various papers which are likely to see a change and new molecules being utilized for fatty liver disease. Weight loss, as I said, that more than 10% is an expected weight loss, but the compliance is less than 10% at the end of 1 year to achieve weight loss. The diet, Mediterranean diet is the recommended treatment, dietary modification for fatty liver disease, and those who maintain this Mediterranean diet for longer and longer duration of period, the expected improvement is expected to continue for a prolonged period. So there has been a lot of people who have been taking a lot of nutraceutical products for fatty liver disease, and is it really recommended or not? So this publication looked at vitamin E, glutathione, omega-3 fatty acid, and they say that healthy diet is the majority of the best of the choice, but we can use specific supplements which can enhance the efficacy of dietary intervention in overweight obese patients with NAFLD. So they can be considered, but they should not be a prime target. We all know that weight loss is the prime target. So whether weight loss achieved with or without exercise, does it matter? We all believe that exercise is most, but this recent publication actually counteracted that by saying that sometimes physical resistance training, even if you achieve a weight loss without exercise, it is equivalent. Coming to the pharmacotherapy of fatty liver disease, I would not go into the various stages at where it is being used, but the landmark paper which was published in 2010 by Arun Sanyal and group, which started and promoted vitamin E and pioglitazone as the treatment of choice for fatty liver disease. Coming to vitamin E, recently tocotrienol is available in the market. Theoretically, T3s possess a stronger antioxidative, anti-inflammatory, anti-obesity and insulin sensitizing properties. And in this recent publication, it has shown that it has equal benefit in treating as compared to alpha tocopherol in treating fatty liver disease, but it is more potent than alpha tocopherol in reducing body weight, inflammation and apoptosis. So T3 or tocotrienol may have slight advantage over alpha tocopherol in patients with NAFLD. Coming to pioglitazone, I think everybody is aware that it has shown significant benefit in fatty liver disease. If you look at in 18 months outcome, there was significant improvement in NASH activity score, resolution of NASH were much higher as compared to placebo, and there was significant improvement in fibrosis. But if you look at the dose that was utilized, it was 45 milligrams. So I don't think that any of us have been using 45 milligrams of pioglitazone for the treatment, and the question that arose was a lower dose effective or not? So this trial was published 1 year back. They said that changes in NAFLD indices were similar even with different doses of pioglitazone. So even if we use 15 milligrams, it has shown equal benefit as compared to 45 milligrams of pioglitazone. Coming to the next group of agent, that is PPAR agonist, they are being promoted now a lot. So one of the agents is saroglitazar, the other is elaglitazar. Pioglitazone is already being utilized. Now, our PPAR gamma activity has sugar lowering activities, while PPAR alpha has triglyceride lowering activities. So by different combination, the expected improvements may be different. So saroglitazar, which is again INSL approved molecule for treatment of fatty liver disease in non-diabetic as well as diabetic patients. It has shown significant benefit in steatosis reduction as well as in NASH activity reduction. And in recent presentation last year, it has shown that it may have nearly 30% reduction in the fat content of the liver, and which may corroborate to improvement in fibrosis. Elaglitazar, which is similar to saroglitazar, which is recently published, also has shown significant benefit in liver fat content as well as fibrosis improvement in form of NAFLD fibrosis score, or as well as FIB-4 scoring in patients with NAFLD and type 2 diabetes. Lenifibranor is a pan-PPAR agonist agent. which has also shown benefit in patients of NAFLD with resolution of NASH. So PPAR agonists are the recommended treatment for fatty liver disease as of now, and newer molecules with similar activity are likely to come in the upcoming years. Elafibranor, I think, is out. Again, the other group of agent is GLP-1 agonist. So, LEAN trial, which is published in 2016, which utilized liraglutide for weight loss and fatty liver improvement, and that had shown significant improvement in SGPT as well as histological improvement in liver with significant reduction in weight. So that started all the interest in GLP-1 RAs. And last year the publication of semaglutide in NASH, where they used subcutaneous semaglutide, and they had shown that there was significant improvement in NASH without worsening of liver fibrosis. But there was no improvement in fibrosis, but we assume that if on a prolonged period there may be improvement. Whether oral is effective as subcutaneous, Japanese study corroborated that even if you give oral semaglutide, which is now available in India, to show improvement. Just one more minute. Compared to all the GLP RAs, dulaglutide, which is more commonly used, does not show very important in this meta-analysis. It is liraglutide and semaglutide has shown treatment for fatty liver disease. SGLT2 inhibitors, again very commonly used nowadays, and this recent publication where dapagliflozin 10 milligrams per day when used for 12 weeks had shown significant benefit in fatty liver disease. When we compared SGLT2 with semaglutide, I think GLP-RAs has slight benefit over obese patients because of a better weight loss. Compared with pioglitazone, SGLT2 shows equal benefit in treatment of NAFLD patients with type 2 diabetes. So in diabetic patients who are suffering from NAFLD, you can give either of the three agents for treatment, though pioglitazone is the official recommended treatment. Obeticholic acid, just a word of caution, which is now being commonly used. The official trial, Flint trial, where they showed 25 milligrams per day is effective, but it has its own side effects, it has its own hepatotoxicity, and its use FDA approved only for primary biliary cholangitis. It should not be routinely used in fatty liver disease. Just a patient with dyslipidemia, I think ezetimibe with rosuvastatin again has shown benefit in patients with fatty liver disease. So besides vitamin E, pioglitazone and saroglitazar, there are molecules which are routinely available for diabetes, which can be considered in the upcoming year, and there will be more data supporting these things. So this is my last slide to conclude that non-invasive test does not just mean fibroscan or elastography. There are simple tests which we can all do at our clinic to rule out fibrosis. Vitamin E, the current recommendation for non-diabetic patient, but new anti-diabetic agents have shown significant benefit, and it is the individualized care that is the need of the hour. So we need to target whether the patient is obese, dyslipidemic or diabetic, and we need to target our treatment according to that. Thank you.
Thank you, Dr. Patel. Thank you, Dr. Parikh, for a brief overview. Any question from the floor?
I just have one question. I think Kaushal sir is also here. If my understanding of the reading is correct, vitamin E was not indicated for diabetic patients because of the original PIVENS trial that was an exclusion criteria. Do we have data to actually support this fact that if you are diabetic, you should not be given vitamin E?
No, there's no data to support. I think Kaushal sir is here, he would be.
So in nutshell, I think...
Yeah, I agree it is not contraindicated. You are right, it was excluded from that particular trial. Subsequently, there have been other trials, although retrospective, which have shown that vitamin E can be given in cirrhotics and diabetics.
But I agree with Kaushal. I think to begin with, the trials were conducted when they had excluded non-diabetics. Now it is supposed to be equally effective and there is no more a contraindication.
But sir, even in our current guidelines, which is published today, we have just mentioned it that it should be utilized in non-diabetic patients.
Okay. Duration of treatment for vitamin E.
I think, there is no endpoint as of now to give the treatment duration for vitamin E. I think it is mainly basically targeted at the lifestyle modifications till we achieve the endpoint of weight loss, which I usually give to protect.
So in that trial, it was for 2 years, but there was a retrospective study in which they had given for a mean period of 5.8 years. So as long as that, 800 units per day. So increased mortality has been debunked by subsequent studies. Large meta-analysis have shown that in fact, this particular retrospective study shows that it reduces all-cause mortality. Not only liver-related mortality, but reduces all-cause mortality. But yes, there is a finite risk of CA prostate.
So for want of time, because we are running late, we close this session and proceed for the next lecture. Thank you very much. Thank you, Basak.
Now we'll start our case-based panel discussion. A 25 years female, hepatitis B and hepatitis C, negative and high SGPT. For that, I will invite Dr. Anil Arora sir, Dr. Venkat Iyer sir, Dr. Akash Shukla sir and Dr. Pankaj Gupta sir as a chairperson.
They are a panelist.
Sorry, as a
Esteemed
panelist. The speaker will be invited by the panelist.
Without wasting much time, may I request Dr. Kaushal Madan, who is a dear friend, he is Director of Clinical Hepatology at Max Hospital, Saket. He is going to take us through a very interesting case of elevation of enzymes and how do we go about deciphering the various causes in the day-to-day practice. Dr. Kaushal, please.
Thank you once again to Yogesh for this invitation. And since we are running short of time, Dr. Anil Arora has a flight to catch. That's why he is in a hurry. So we'll start with this case-based panel discussion. Very simple. I think you've already heard Pathik talk a lot about this, what we will be discussing now. So it will be like a post-test for all of you. So what I'll be doing is, before posing the panelists the question, I'll pose the question to the audience and then the esteemed panelist. And if you also have a question, you ask them because they are the expert. Don't ask me. So this is the case. So don't worry, it's only one case because out of habit I've written case one. So Mrs. NP, 25-year-old lady, referred for raised ALT detected during workup of dyspepsia. Social drinking habits, no history of any percutaneous exposure, no family history of liver disease. Except that she gave a history that one of her maternal grandfather possibly had hepatitis B, but she was not sure. Non-hypertensive, non-diabetic, BMI elevated, 28.9. These were the labs: AST 48, ALT 92, platelets 1.9, INR normal. This was already given, HbAg NT-HC negative. This was the lipid profile: cholesterol 215, triglyceride 198, LDL 110, HDL 46. So question to the audience, what do you think the patient might be having? We'll not waste much time here. You can shout out. Okay, everyone thinks NAFLD. She did give a history of possibly hepatitis B infection in her maternal grandfather. Now a doubt. Okay, but still everyone feels it is NAFLD. So the first question to, I think, Dr. Venkat, what do you think the patient might be having and your reasons?
Yeah, so given the fact that this lady has a slightly higher BMI, of course the Indian criteria are a bit more rigid regarding the BMI. So, and also apart from the SGOT, SGPT elevation, she also has a fatty liver. So that I would go in favor of NAFLD.
No, we
I
don't
think
have
ultrasound is not available,
no,
right?
No, we don't
ultrasound
have
is not yet
so
available.
So at this level, if you have to make a diagnosis.
Yeah, so I will go ahead with the ultrasound. I would like to.
Yeah. So I think if we look at this study which we did at AIMS, 67 patients with transaminasemia who were B and C negative, after a 3-step diagnostic algorithm, most common diagnosis was NAFLD, and this was in 2005. But believe me, if you do this kind of study now in 2020 or 2022, 50% of patients will have NAFLD, and if you look at studies from all over the world, they also suggest transaminasemia, 50% chance patient will have non-alcoholic fatty liver disease, and I think the panelists would agree on that.
Sir, Dr. Akash has also joined now.
Yeah. So next question is for him. And the next question is for Dr. Arora. So, to the audience, what should be the next test? Ultrasound upper abdomen, fibroscan of liver, lipid profile, fasting serum insulin. It's a insulin resistance syndrome. What?
Lipid profile, you have already mentioned, Kaushal.
Yeah, so you can exclude C. What else? Good. I think that's what I wanted to hear. So, Dr. Arora, and your reasons for that.
Yeah.
That's why you are the experts.
See, if, first of all, another thing we should remember is one should not keep on extensively investigating a patient with single ALT. First thing you have to do is repeat ALT. Second important thing is you should always take a history of drugs. Most of the patients who are taking the drugs which are available as OTCs, over-the-counter drugs, they don't think they are taking drugs like Brufen or NSAIDs or even the young lady oral contraceptive pills are extremely important. So first is repeat the liver function to be sure that you are talking about abnormal ALT, and secondly do take a history of drug which may be innocuous for the patient. Herbal drugs, complementary and alternative medicines, NSAID, these are the common chief culprits for causing disease. And once you have a setting like this, lipid profile is normal, I think first thing we should do is an upper abdominal ultrasonography just to look at the physical characteristics of the liver and look for an evidence of chronicity. That is the first thing you need to do.
Right. So I think that very important points which he has made. Repeat, confirm that ALT is really elevated, rule out other causes, and I think we'll come to that in the subsequent discussion. And yes, the first thing to make a diagnosis of fatty liver is ultrasound, not fibroscan. Do not jump to fibroscan immediately. And this is how it is diagnosed, a bright liver in comparison to kidney cortex. So if you have this kind of image, you see this is a black kidney cortex and a bright liver as compared to this is fatty liver. That's how they grade as grade 1, grade 2, grade 3. So grade 1 is just a bright liver, grade 2 is loss of vascular details, and grade 3 is loss of deeper echoes. Normally you would see a bright line here which would represent diaphragm. When you are not able to see it, that's when the ultrasonologists call it a grade 3 fatty liver. So it is so subjective. Although they have tried to make it objective, but believe me, it is subjective. Okay, so you made a diagnosis. Have we missed anything before we make a final diagnosis of NAFLD to the audience? Pardon, sir? Sugar, okay. What else? So, Dr. Akash, have you joined us? Are you there?
Dr. Akash is there?
Great, Akash. So, before we make a diagnosis of NAFLD, which everyone is trying to make, have we missed anything here?
Sorry, Kaushal, I could hear Dr. Arora very clearly, but your voice is not as clear.
So, Akash, before we make a final diagnosis of NAFLD, have we missed anything here?
Akash, the question is, do you need more investigation before saying it is NFL? Would you like to exclude something else?
Yeah. So we always exclude viral hepatitis in patients with NAFLD. So hepatitis B and hepatitis C, drug-induced hepatitis. And if the clinical setting is appropriate, then we would also want to rule out other causes like Wilson's disease and autoimmune hepatitis, because even NAFLD can coexist, or the patients may actually have fatty liver, but they may actually be suffering from Wilson's disease or autoimmune hepatitis also. So, and in adolescents and young, we would want to rule out metabolic liver disorders and storage disorders before we label anybody as NAFLD.
Kaushal, can I ask him a question?
Yeah, please.
In private sector, every test costs hell of a money. So do you subject the patient to battery of tests, serum, ceruloplasmin, copper, ANA, ASMA, because patient को लगता है कि डॉक्टर साहब के पास गए थे 25,000 का बिल बना दिया. So where do we stop and what do we do?
So, sir, what I think we have to do is, like I said, in an appropriate clinical setting. So if I have a 25-year-old boy who has come to me with fatty liver but enzymes are 150 and 130, I would want to rule out Wilson's disease, so I would do Wilson's disease workup. and ANA, SMA and IgG as well in this patient. If it is a 60-year-old, obviously we will not be doing. So it all depends on the clinical setting. If I have a 45-year-old lady who has got fatty liver on ultrasound but also has high enzymes more than 100 consistently, then I would always want to rule out autoimmune hepatitis in this lady. So it depends on the clinical setting, and therefore you have to use your clinical judgment in which test to order. Blindly ordering all tests for everybody is futile, because very often you will get ANA positive 1 in 40, 1 plus, 2 plus, 1 in 100, 1 plus, 2 plus, which has no meaning whatsoever. So therefore it has to be done in the right clinical setting.
Right. So I think the most important message here is that it's also a diagnosis of exclusion. You have to exclude a number of things, most importantly alcohol. And I'll come to that, and I'll talk, we'll ask Dr. Pankaj how much alcohol would he consider as being responsible for alcoholic liver disease. But before that, Akash, why don't you, Dr. Arora did talk about herbal drug intake. I think you have some experience over last couple of years what has been happening. Would you want to share that about herbal drugs induced liver injury?
Are you asking drugs which cause fatty liver?
Maybe you can.
Yeah, Akash, the question is, what is the role of complementary and alternative medicine, CAM, in presentation like this? That is what Kaushal wants to know.
So very often there are two situations where we where we get confused because of the use of CAM. One is in patients who have been taking CAM and then develop a new onset liver disease. There of course it is easier, because there you can, if you rule out other causes and if the other clinical features, histological features are consistent, then you can call it CAM related, complementary and alternative medicine related drug induced liver injury. But what is more common is patient starts getting a liver disease, gets jaundice, and then starts taking complementary and alternative medicine as a treatment for the jaundice or for the liver disease. And there very often we will, it may be very difficult to pick up what is the component of the drug induced liver injury, and very often it adds to the primary liver disease, complicates it further, and we have had even acute and chronic liver failures because of that. And the other issue is the only way to identify whether the persistent symptoms or the worsening is because of drug induced liver injury or not is by either eosinophilia in the urine, eosinophiluria, or if you look at the hepatology, and that shows the classical drug induced liver injury.
Right.
A third situation which we have seen in the last 3 years especially is, some of these tenospora which causes unmasking of autoimmune liver disorders. So if somebody is taking supraphysiological doses, self-medicating with tenospora, then that can actually unmask in somebody who has a tendency for autoimmune hepatitis, because it's an immunity booster, they develop features of autoimmune hepatitis. So I think these are the three situations which we face commonly.
Right. Thank you, Akash. So Dr. Pankaj, how do you exclude out alcohol intake? Because that's a very important part of definition of non-alcoholic fatty liver disease.
In a dry state we are sitting, and before me I would like to ask the audience how they calculate the alcohol intake. How they calculate the alcohol intake. Is there any concept of converting into grams, or you are calculating in volume? No. So change one practice. It's a message giving, change one practice, calculate in grams, and 60 to 80 grams for male and half of that for female. If they are taking continuously for decade, at least 8 to 10 years, and not all of them are going to develop this cirrhosis, only 10 to 15% of them are going to develop.
Provided the patient gives the correct history.
Yeah.
Right.
Alcoholics are always liar. So their relatives are more reliable if we are taking history,
So
and
the sur-
convert the alcohol into grams.
Right. So surreptitious alcohol use, is it more common in a dry state, or I don't know?
I have trained myself in PGI and Vellore, and in Gujarat I am seeing more alcoholic cirrhosis than my
The other two
erstwhile
states.
institutes while I got trained.
That's the answer.
Actually, in morning presentation, I quoted one study from Bihar, that is also a dry state. in which there is an equal contribution for ascites with alcoholic cirrhosis and
But
tuberculosis.
non-alcoholic. Right.
So there is a somewhat lesser.
Prohibition is the hidden secret of Gujarat.
So we have a final diagnosis of non-alcoholic fatty liver disease.
Can I add something here?
Please, Akash.
Yeah, so, the history given by the relatives about the quantity of alcohol is actually a much more underestimation, much lower than what the patient is actually consuming. This has been studied and proven in at least 3 studies where the family members actually underreport the amount of alcohol that the person is consuming because they're simply not aware. Because the patient drinks something in front of them, he is drinking much more when nobody is around.
Right.
So I think that is also something which you have to keep in mind. So the person who is most likely to know the truth and tell you the truth is actually the patient himself, as long as you can gain his confidence.
Right. Very important point which Akash has made. So let's move. We have made a diagnosis of NAFLD. After establishing NAFLD, what should be done next? The question to the audience. A liver biopsy, a fibroscan, start ursodeoxycholic acid, or I think Pathik told us that pioglitazone is one of the drugs which can be used. So start pioglitazone. So what do we do? I think everyone knows everything about NAFLD. So Dr. Pankaj, so what is your next step and why? And we'll come to ursodeoxycholic acid subsequently.
Of course, fibroscan the next test because we should know the quantitation of the damage, and that is later on after treatment we can also compare if the patient is improving or not. So fibroscan is a good tool for the monitoring and quantification both of the disease.
Right. So I think after making a diagnosis of fatty liver, it's very important job for the physician to diagnose whether it is a simple fatty liver or an advanced fatty liver. Advanced fatty liver is called NASH. We loosely use the term NASH to describe all kinds of fatty liver. So simple fatty liver versus NASH. Why is this important? Because NASH involves demonstration of ballooning hepatocytes and malloryhyaline and fibrosis. Because it is NASH which has a poor outcome or a lower survival than the control general population. Pure fatty liver has same survival. So if you have just fatty liver, you are as good as a normal person. But if you have NASH, you have a poor survival, and the risk of dying is because of cardiovascular diseases, extrahepatic malignancies, and third comes liver related causes. So how do you make that distinction? It is either by liver biopsy, which 99.9% neither you want to do nor the patients want to do. So you have to depend on non-invasive marker. Pathik talked about all those non-invasive markers, but the simplest and an OPD tool is fibroscan. So this guy had a fibroscan which gave us 2 values, a cap value which tells us how much fat, 332, and a E value, that is fibrosis, 10.1 kilopascals. So with the diagnosis is NAFLD, NASH with advanced fibrosis. So he has advanced fibrosis, advanced kind of fatty liver disease. So question to the audience, what would your management approach be now? Start saroglitazar, start vitamin E, start pioglitazone according to the guidelines, or none of the above? So एक question तो गलत किया. So I think, let me ask, Dr. Arora has gone, so Dr. Venkat, you can take this question.
So the thing is that this NASH is basically a lifestyle disease. So first of all, like I would like to target on the lifestyle of the patient. So first thing is counseling the patient and asking the patient to make appropriate lifestyle modifications so as to, induce at least 5 to 10% of weight loss and also increase the physical activity. So that would be the first thing to do once a patient is, like it should not be a knee-jerk reaction that you are diagnosed and chalo. Actually the patient also likes that you spent a hell lot of money in diagnosing me and koi dawai to likh ke di nahi. So that's the kind of approach the patient has, but that is the truth. So nothing works better than lifestyle modification.
So first treatment, lifestyle intervention. That is the most durable treatment, not pharmacotherapy. If you see the vitamin E pioglitazone trial, you stop the treatment after 96 weeks and the AST ALT bounce back to the previous levels. So unless you improve the lifestyle, pharmacotherapy is not going to help. So first treatment, lifestyle; second treatment, pharmacotherapy. And he did talk about that. If you are able to lose 3% body weight, there is a reduction in liver fat, 5% body weight reduction in ballooning inflammation, 7% body weight NASH resolution, and more than 10% body weight improvement in fibrosis. This is a pyramid of how it works. But importantly, only 30% were able to achieve at least 7% weight loss. So most are not able to achieve that. In them and in lean NASH, maybe you need pharmacotherapy. So question again to the audience. We are almost towards the end. If you have to start pharmacotherapy, what would it be? Ursodeoxycholic acid, saroglitazar, vitamin E, obeticholic acid. Pardon? Vitamin E. Somebody said vitamin E. And? So everyone starts vitamin E or somebody starts something else also? Okay, how many of you start these patients on UDCA? Let's have a show of hands. I also used to do that earlier, but not now, right? So all panelists, so open to all panelists, if you have to start pharmacotherapy, what would it be?
So definitely not UDCA. Choices between saroglitazar and vitamin E, and sometimes co-therapy with both saroglitazar and vitamin E. OCA, although it has lot of trials, the Flint trial, I think in the previous presentation Pathik also mentioned that it has not yet, the evidence is not yet still there for OCA for NAFLD, for
Right.
NASH.
Dr. Pankaj?
Some customization should be there. If patient is an old male, then you should avoid this vitamin E. Otherwise, for female, the first line of drug of choice is vitamin E. It's very cheap. Even other congeners of vitamin E like gamma, alpha, tocopherols,
Right.
they are also can be given. And saroglitazar are also maybe the first line of treatment, especially in patient with the diabetes and overweight.
So we have 3 drugs available in the market, all 3 lower ALT. Saroglitazar, vitamin E significantly improves fat, and only OCA is shown to improve fibrosis. Vitamin E in a retrospective study has also shown to improve liver-related and non-liver-related outcomes. Adverse event wise, OCA is the one which is associated with maximum side effects, and OCA has not been approved. No talk about NAFLD is complete without talking about UDCA. So this was the first trial, first RCT of UDCA versus placebo. UDCA was not found to be better than placebo, as bad or as good as placebo. Another study, I'm just finishing, higher dose of UDCA, 22 to 28 milligram per kg, again a randomized control trial, not better than placebo. Then they thought, let us give another higher dose. So they gave 28 to 35 milligram per kg body weight, another RCT, comparing a higher dose. Here they found that there was a mild improvement in the ALT levels. But this dose, no one can tolerate such high doses of UDCA, you will develop diarrhea. So I'll just finish here, take home messages. Most common etiology of asymptomatic rise in transaminases in most populations of the world is NAFLD, but you have to exclude alcohol, viral, importantly drugs and autoimmune hepatitis. Job of the physician is to classify into simple fatty liver and NASH. Simple fatty liver, all kinds of fatty liver. First treatment is lifestyle measure. Target a weight reduction of 10% with diet and exercise. Pharmacotherapy for severe form of NAFLD, that is NASH, in addition. Fibroscan is a handy tool which can, in OPD, help you make this distinction between simple fatty liver and NASH. Thank you for...
Sir, last question. Is there any indication to treat patients with vitamin E and saroglitazar both, combined treatment?
Yeah, so there is no study suggesting that, but patients who have advanced fibrosis and you want to be aggressive, then off-label use, you can use both. But in terms of approval from a regulatory authority, saroglitazar is the only drug which has been approved for use.
Sir,
but again, monotherapy.
So again, sir, like if you have a patient in whom pharmacotherapy is indicated, what you will choose, vitamin E or saroglitazar? And if vitamin E, why? Saroglitazar first choice, why?
Okay, so if it's only an improvement in fat and improvement in AST, ALT, and patient does not have fibrosis, then saroglitazar or vitamin E, both will work. And if there is also fibrosis, then possibly if you ask me, I usually combine the two. There may not be any rationale, but yes, vitamin E has an antioxidant effect, which may lead to a reduction in progression of the disease, as shown in that retrospective study.
Thank you, sir. Thank you.
Dr. Kaushal, one question can I ask?
Sure, sure.
So as he has highlighted pioglitazone, do you use in your practice because concerns of weight gain and cardiovascular mortality is there? So whether you use that for NASH in your setting?
And just an extension to that question, do you use it in a non-diabetic?
Yeah,
All diabetic
both are very important questions. Hepatologists are not very well used to using pioglitazone, diabetologists are. So between the two, although both were approved, both were recommended by ASLD, hepatologists are more comfortable using vitamin E. So yes, one of the concerns is pioglitazone or all these glitazones can cause weight gain. So an average of 3 to 4 kg weight gain, which becomes counterintuitive. You are asking the patient to lose weight by lifestyle intervention, and here is a drug which is causing a weight gain and discouraging the patient. So I usually don't prefer pioglitazone. Your point was? Sorry.
Pioglitazone in a non-diabetic, according to the previous trial.
It can be used in non-diabetics also.
I mean, I just wanted to know your experience with it.
No, I don't use it.
Thank you. Thank you. Thank you, Dr. Akash Shukla, for being with us. Thank you, Dr. Pankaj and Dr. Venkatayar and Anil Arora, sir.
Thank you, sir, and thank you, Chairperson. Now, the last topic is endoscopic management of NAFLD. For that, I would like to invite Dr. Anand Patel, sir, Dr. Avinash Tang, sir, Dr. Venkatayar, sir, and Dr. Javed Sheikh, sir, as a chairperson.
So, this is last topic for today, but not the least. Tomorrow we are coming back with more energy. So, see you tomorrow again at 9 a.m. after the quiz and inauguration session. And tomorrow there are very important topics on pancreas and IBD with renowned faculties.
Yeah. So thanks, Yogesh. My pleasure to, good friend Yogesh, and, very aggressive endoscopist, and I should congratulate you on the very successful meeting. I will go to the topic of endoscopic management of liver.
So, we will discuss endoscopic management of fatty liver. So, the outline of talk will be to understand why weight loss is important to treat NASH, type of endoscopic procedures, evidence of endoscopic procedure for treating NASH, and whom to choose for endoscopic procedure, and a proposed algorithm. So, the prevalence of fatty liver in India is 40%, and we all know that this fatty liver can convert into NASH and cirrhosis, hepatocellular carcinoma, and hence treating is very important. So, if we see the NAFLD spectrum, fatty liver occurs, and out of this 30% of the patients develop NASH, that is inflammation, and of this 30% of the patients, 20% of patients will develop fibrosis, and 2 to 13% of patients will develop HCC with cirrhosis. But if you see this group in which only fatty liver and NASH, even they can develop HCC, those patients who don't have cirrhosis, they can develop HCC. So it doesn't mean that if on USG you have fatty liver, just forget it and take it casually. You have to keep these patients on regular follow-up. So we all know this multi-hit hypothesis. I won't spend much time here, but the dietary factors and obesity, they lead to increase in cholesterol, increase in free fatty acids. Free fatty acid leads to lipotoxicity, mitochondrial dysfunction, increase in reactive oxygen species, inflammation, apoptosis, and NASH. Simultaneously, in fatty liver, there are increase in adipokines, tumor necrosis factor alpha and IL-6 increase, which again lead to mitochondrial dysfunction and NASH. Also, insulin resistance occurs in obesity, which leads to increase in free fatty acids and lipotoxicity. So, insulin resistance is pivotal for the progression of NAFLD from simple steatosis to NASH. So, the idea is to decrease this insulin resistance. Insulin resistance impairs the ability of insulin to suppress lipolysis, increases the fatty acids in the liver, and it also leads to de novo lipogenesis.
So why do we need weight loss in NASH? Because it leads to increase in insulin sensitivity. Weight loss will lead to decrease in lipotoxicity and mitochondrial dysfunction, and it will also lead to increase in GLP-1. GLP-1 will lead to satiation, decrease gastric emptying, and increase in insulin sensitivity, which will promote weight loss. That's why weight loss is very important in NASH. So coming to treatment of NLD, it has already been discussed. Exercise and diet is must. Vitamin E, pioglitazone, saroglitazone, all are evidence-based medicines. Liraglutide and semaglutide, again they are evidence-based. But vitamin E and saroglitazone, they do not help in weight loss. Exercise and diet, yes. Liraglutide and semaglutide, yes. They reduce weight, but are they adequate to decrease NASH and prevention of cirrhosis? Let us see that. This slide has been shown in previous presentation also. So to reduce NASH, at least more than 7% of weight loss is required, and to prevent fibrosis and to induce fibrosis regression, more than 10% of the weight loss is required. So lifestyle and dietary changes, though they are fundamental for any treatment plan, they are very difficult to sustain and they are not enough for morbid patients. What does this study by NEGM says? That lifestyle intervention will reduce only 2 to 9% of the weight loss, Medical therapy again will reduce only 2 to 9% of the weight. Bariatric surgery, yes, it will reduce a significant amount of weight. So what do I want to say? That the background is dietary and lifestyle modification often fail to achieve desired weight loss outcomes. Pharmacotherapies are available, they are good, but they are associated with many contraindications and they have less rate of compliance. Surgical approaches have been successfully used to treat NASH, but again they have a risk of mortality 0.1 to 3% as well as morbidity. So what are the interventions in NASH? First is bariatric surgery, and other new on the chart is endobariatrics. So let us go through surgical management strategies. Here is the study which is published in Gastroenterology 2015. They have clearly shown that bariatric surgery reverses fibrosis as well as non-alcoholic steatohepatitis. Another study published in AASLD in 2018, they also shown very clearly that this bariatric surgeries, they reverse NASH as well as fibrosis very significantly. But they are associated with morbidity 3 to 20% as well as mortality 0.1 to 2.5%, and it is not also acceptable by most of the population of obese patients to go for a bariatric surgery. So do we need any other form of therapy? So the available therapy, as I told you, lifestyle therapies, not adequate, difficult to sustain, they cannot achieve desired weight loss. Medications have various contraindications and compliance is an issue. Bariatric surgery, though is the gold standard, but it is low acceptance, cost is high, mortality is there, and it has to be avoided in cirrhosis. So can we offer something good, less invasive, and more reliable to those patients who have BMI from 30 to 40? So let us discuss through the endoscopic methods. There are two endoscopic methods which are widely practiced. First is space occupying devices, which is intragastric balloon, and other is gastric volume reduction, which is endoscopic sleeve gastroplasty. So intragastric balloons are very simple. They have restrictive effect, increase the feeling of fullness, early satiety, and slow gastric emptying. And they are indicated for those patients who have body mass index less than 40, or those who are sober, obese before surgery, and those who have lower BMI but significant comorbidities. And the median excess weight loss is around 30%. Now this is for those who have fatty liver or may not have fatty liver. But what does the literature say of use of intragastric balloon in case of fatty liver? Here you can see that the body mass index, weight, waist, the AST-ALT levels, HbA1c, APRI, that is ratio of the ALT and platelet, NFLD score, and KPA values, that is the elastography values, all are significantly improving with intragastric balloon placement for those patients who were between BMI 30 to 40. This is another study which clearly shows that use of intragastric balloon for BMI 30 to 40, there is increase, there is regression of the fibrosis stage and decrease in stiffness. Next we come to endoscopic sleeve gastroplasty. This is a technique in which we put permanent sutures endoscopically to narrow the volume of the stomach. And this is done transorally, which leads to endoscopic gastric volume reduction, and it is FDA approved and now also commercially available. So this is a simple device by which we take sutures. I would like to run through a video in which you can see the stomach. We mark this stomach by an APC along the greater curvature as well as the posterior wall of the stomach, and then we start putting sutures. These sutures are placed in a U pattern from greater curvature to the posterior wall of the stomach, and we take total 4 to 6 sutures, which finally leads to creation of a sleeve. And this sleeve is almost similar to what surgeons do in laparoscopic sleeve gastroplasty. So this is, you can see, a formation of a sleeve, a very well placed sleeve, and this helps to reduce the weight. So let us see what does the literature says. Literature says that the technical success in endoscopist hand is almost 100%, median weight loss is 18% in 1 month, and almost up to 40% at 6 months. So let us go through the data which has come recently from Indian group from Asian Institute of Gastroenterology. Dr. Rakesh Kalpala and Nitin Jagtap has shown in their study that when they studied ESG in 26 patients with NASH whom hepatic steatosis index were high with a median BMI of 36, ALT, hepatitis steatosis index, NASH fibrosis score, FIB-4 score, and EPRI all improved very significantly. The p-value was significant, suggesting that ESG will lead to improvement in NASH as well as NASH fibrosis. So the proposed algorithm is that whenever you get a patient who has obesity and liver disease, that is non-alcoholic steatohepatitis, always motivate this patient. Obviously, diet and exercise are the foundation, but if they fail and if they have BMI of 30 to 35, you can always give GLP-1 analog in intragastric balloon. If their BMI is high, if they don't have diabetes, then you can go for intragastric balloon or ESG. If diabetes, you can add GLP-1, and obviously if the BMI is high, there is not much role of endoscopic therapies, you can advise them for surgery. So my take-home message is that progression of NAFLD to NASH cirrhosis has to be intervened. Diet and exercise are fundamental but are not sustainable. Endoscopic modalities are less invasive, safe for BMI 30 to 40, and have evidence for treatment of NASH and fibrosis. Thank you.
It's a wonderful presentation. I just need to highlight that you have quoted that any patients more than 30 BMI should be preferred for endoscopy. But I would strongly say that there are the large group of the patient whose BMI is less than 30, but still they have a fatty.
Yes.
So I would say that more than 25 of BMI and they have tried conservative treatment and they failed, I think ESG should be offered to them also, if there is a NASH.
Yes. Yes, doctor.
So very good presentation. Just a small comment is that we don't have to look at fatty liver disease as a disease. It's just a part of metabolic syndrome. And by doing the endoscopic procedures to induce weight loss, we are actually addressing to the larger picture of the metabolic syndrome. And it also, of course, benefits NAFLD.
So my humble request, I know it is late, but in our conference, nothing is ending before we inaugurate. There will be a lamp lighting, please be there. And after that, we'll conduct the quiz. Thank you.